for the symposium. That is, while most of the participants will join in online, there are few participants who have joined us here at the auditorium of the new dental school building at Eric William Medical Sciences Complex. We have a distinguished group of presenters who will shed light on COVID-19 vaccines, their development, efficacy, safety, and their rollout in Trinidad and Tobago, including Professor Christine Carrington from the Faculty of Medical Sciences, Dr. Carla Maria Alexander, also from the FMS, PWI, Dr. Wheeler, Dr. Parasram, Dr. Vidar Harsa, who's from the Faculty of Medical Sciences, Dr. Daniel Solomon from the Harvard Medical School, Dr. Mike Campbell, who is from the Faculty of Medical Sciences on the Cayfield campus. Just to note that both Drs. Solomon and Campbell will be joining us virtually. To get things going, I will invite Professor Simongal to deliver his welcome address. Professor Simongal is the Dean of the Faculty of Medical Sciences at UWI St. Augustine campus, which comprises 5 schools: medicine, pharmacy, dentistry, veterinary medicine, and nursing. He completed his MBBS with honors degree at UWI and then proceeded to London, where he did a PhD examining COPD and COPD exacerbation caused by respiratory viruses, and completed his specialist training program in internal and respiratory medicine. He returned to Trinidad and Tobago in 2003 as senior lecturer in medicine, and in 2008 he started the postgraduate training program in internal medicine. Professor Simongal is a key member of the UWI COVID task force. Professor Simongal, please.
Good morning, everyone. Great pleasure. It was rather good afternoon, everyone. Great pleasure to be here with you all and to welcome all of you. I must acknowledge the presence of our Minister of Health, of course, and our Chief Medical Officer, and to say what a great pleasure it is for us here in the Faculty of Medical Sciences to share this very important symposium with the Ministry of Health. I would like to say just very briefly that COVID-19 has been a challenge for us, as I know it has been for all of you, but we have stood by this country and the Ministry of Health as it faced up to the challenges and directed us. And I recall that the Chief Medical Officer turned to us for the latest in therapeutics against this virus, and we responded, a team that was led by our own Professor of Pharmacology. We very quickly moved our teaching to online, and then perhaps the crowning success of it all was our postgraduate exams, which we were able to hold in December. And finally, a vaccines review that we did. Of course, there have been a lot of other collaborations, but importantly, if you look at how we have approached, or how the world has approached COVID-19, the past year has been an era of non-pharmaceutical interventions. And we are now moving into what I might call the pharmaceutical preventive era. So that's when we begin to use pharmaceuticals that are preventive in nature. That is quite a challenge because while vaccines have been extremely helpful, for instance, they have helped us to eradicate smallpox and were poised to help us complete the eradication of polio, there has been some failure. But the failure has not been of a vaccine itself. It has been of the approach of populations to the vaccine. And that is a vaccine that is well known. So we anticipate, and the Ministry of Health has been leading us in this, in anticipating that there are going to be difficulties in rolling out the vaccine. And there is a need, first of all, to educate our healthcare practitioners. And I want to thank the Caribbean Center for Health Systems Research and Development for leading the faculty in several of its interactions with the Ministry of Health. And I really appreciate the leadership and advice of Professor Simeon here throughout, especially throughout the past year. So we were extremely pleased when we were able to get Dr. Daniel Solomon of Brigham and Women's Hospital from Harvard Medical School to let us know his views on overcoming vaccine skepticism and hesitancy and strategies to optimize uptake. It took a bit of negotiations to get Dr. Solomon, but we are extremely happy to have him, and we look forward to his talk, as we look forward to the talks of all our colleagues here, Professor Carrington, Dr. Alexander, Dr. Wheeler, our Chief Medical Officer, and Dr. Campbell from the Cave campus, and of course, Dr. Sau, our Deputy Dean. I invite every one of you to a pleasant and I know information-packed afternoon. Thank you all very much.
Thank you, and Professor Simangal, for bringing those greetings. Next on the program is Honourable Minister of Health, Mr. Terence Dayal Singh. Minister was educated at the Curia Presbyterian, then St. Mary's College. He then did a diploma at UWI in pharmacy in 1981. He subsequently earned a postgraduate diploma in international marketing before returning to UWI in 2007 to obtain a Bachelor of Science in Pharmacy. In 2013, he qualified for the Bachelor of Laws from the University of London International Program. Before his stint in politics, Minister Dayal Singh started his career as a lecturer in the Institute of Training and Development, and from 2011, he served as a part-time lecturer in the School of Pharmacy, Faculty of Medical Sciences, right here at Mount Hope. As Minister of Health, Mr. Dayal Singh's main goal is to bring the three highs, that is blood pressure, sugar, and cholesterol, to the three lows. We are very fortunate that he has brought this passion to the management of the COVID-19 pandemic. Minister, I invite you to give your address.
Thank you very much, Professor Simeon. Is my microphone on? Thank you very much, Professor Simeon. Good afternoon, all gathered here today in person, and to those gathered virtually. I would like to recognize some key people who I made sure to invite to this. I would like to recognize Mr. Edie Stewart, President of the Trinidad and Tobago Registered Nurses Association. Part of the reason for having this symposium today is to talk to nurses. I would also like to recognize the Trinidad and Tobago Medical Association. Part of this is to talk to doctors and all the allied health services. I also want to recognize physically in the crowd, so to speak, my parliamentary colleagues, Dr. Rai Ragbir and Dr. Lakram Bodo. We are treating this as a purely non-political event. It's a whole of society, whole of country approach. The former Minister of Health, Dr. Fuad Khan, was invited, and I am told that he has logged on virtually. Ladies and gentlemen, at the start of 1993, Queen Elizabeth II described 1992 as her annus horribilis. For her, 1992 was a particularly tragic year. I am sure we could all agree in this setting that 2020 is the annus horribilis for 7.8 billion people on planet Earth. It has been a year of tragedy. It has been a year where we have seen a new virus, a once-in-a-100-year event, strike 213 countries around the world. It has spared no continent. It has spared no race. It has spared no gender. It has spared no political system. Governments have fallen. Ministers of health have fallen. Economies have been crushed. And over 2 million people have died. That is the annus horribilis that is 2020. In Trinidad and Tobago, we have lost 135 good souls. And our deepest condolences go out to each and every one of those families. That's 135 families who did not spend a good Christmas, who will not spend a good Eid, a good Diwali, who will not be around to bounce their grandchildren on their knees. The world response so far in this annus horribilis, that is 2020 into 2021, has been one of mitigation, risk reduction, the wearing of masks, physical distancing, physical barriers, closing of borders. Our response in Trinidad and Tobago has been recognized around the world by all objective measures as being stellar. We are lucky. But it's not luck. It is a carefully thought out strategy. And for that today, I want to recognize and pay tribute to my political leader and Prime Minister, Dr. Keith Rowley, who believed in the science, What we have been engaged in so far with this virus, with masking, with closing of borders, is management of the virus. We have been engaged in a war of attrition, but that will take you so far and no further. We have to move from annus horribilis and management to annus mirabilis and control. That is where we are now. The tool we will use for that is an old, tried, and tested tool called a vaccine that has been in use in mankind since 1000 BC by the Chinese. With Edward Jenner, the father of modern vaccination programs with smallpox in 1796. So vaccines are not new. Vaccines are not new. Between 1990 and 2016, 2 million lives have been saved due to vaccinations. And I said earlier, 2 million lives have been lost due to COVID. Look at the figure. We could have saved 2 million people if we had a vaccine. We are addressing the issue today of vaccine hesitancy amongst healthcare workers. And I want to speak directly now to healthcare workers. The COVID vaccine to date has been administered to 134 million people around the world already, with little or no adverse effects. But I want to contextualize that by comparing vaccines with NSAIDs. If you look at PubMed, they will tell you that 3,000 to 16,000 persons a year die because of NSAID problems, gastric bleeding. But you don't hear a thing about that. But let one person have a sore arm because they took a vaccine and the world comes crashing down. 3,000 to 16,000 persons a year die because of NSAID side effects. The Telegraph reports that a similar figure, 3,000 persons a year, die because of side effects of aspirin. And here comes the one that you should be concerned about, paracetamol. In England, in 2018, 216 people died because of taking paracetamol. But we have administered 134 million doses of the COVID-19 vaccine and no one has died. Why the skepticism? Because of conspiracy theories, the internet, and let me tell you something. Part of it is driven by money. There is money to be made in promoting vaccine hesitancy. So ladies and gentlemen, as I come to a close, we are moving from annus horribilis. We are moving from management of the disease. We are moving from mitigation. We are moving from this warfare where today we win, tomorrow we lose. We are moving to an era of annus mirabilis, a wonderful year, an excellent year. But to do that, the vaccine is going to save you, you know. what will save you is not the vaccine. What will save you is a vaccination program where the vaccine gets into your arm. A vaccine in a vial is useless. A vaccine in a chiller is useless. A vaccine in your arm to produce an immunological response is what we need. So today, I urge healthcare workers, the same vaccine you have been given out for decades with no problems, lead the way. And I want to recognize Nurse Penny Jagan, who spoke at the Ministry of Health's virtual media conference yesterday. She said, and I quote her, in her 10 years of nursing practice, she has never once had to fill out a form reporting an adverse event in giving out vaccines. But 3,000 people die because they take ibuprofen. 3,000 people die because they take aspirin. Contextualize that, and you could see there is nothing to fear from taking your vaccine. As one world leader said, the only thing you have to fear is fear itself. Ladies and gentlemen, let 2021 be our annus mirabilis. Thank you very much.
Thank you, Minister, for setting the stage for the more formal aspect to the program, where we will be having 7 presentations from experts addressing various aspects of the COVID-19 vaccine response in Trinidad and Tobago. The first presentation will be, before I go into the first presentation though, just to remind all the participants that the program will be in 2 parts. That is, the first session would comprise 4 presentations, after which there will be a question and answer segment. Then we'll have the final 3 presentations and the question and answer, followed by the closing remarks. The first presentation is a project update for the project entitled Infectious Disease Molecular Epidemiology for Pathogen Control and Tracking, COVID-19 Impact. The presenter is Professor Christine Carrington, who is Professor of Molecular Biology, of Molecular Genetics and Virology in the Department of Preclinical Sciences at the Faculty of Medical Sciences at the University of the West Indies, St. Augustine campus. She holds a BSc in Biotechnology and a PhD in Molecular Virology from the University of London. Her primary research focus is understanding evolutionary and ecological factors involved in the emergence, spread, and maintenance of emergent viruses. She is the current head of Department of Preclinical Sciences, a member of the UWI COVID-19 Task Force, and a director of the Global Virus Network Affiliated Center of Excellence at the Faculty of Medical Sciences, UWI St. Augustine. Professor Carrington is the principal investigator for the COVID Impact Project, which is a UWI RDI funded project in collaboration with the Trinidad and Tobago Ministry of Health, CARPHA, the University of Oxford, and the University of London, which has established a local capacity for rapid generation of SARS-CoV-2 whole genomes in order that viral genomics and related molecular epidemiology approaches can be incorporated into the COVID-19 mitigation and control efforts of public health bodies. Professor Carrington, I invite you.
Thank you very much, and good morning to everyone. All protocols observed. Good afternoon, and all protocols observed. And thank you very much to the organizers for inviting me to speak today. Now, over the past couple of months, there's been a lot of concern about certain variants of the SARS-CoV-2 virus that have emerged. And I'm going to talk about these so-called variants of concern. I'll focus on how they arose, what we know about them, And as the chair said, I'm going to talk about a project that we have here at UWI, where we have been using genome sequencing to detect and track different viral lineages, including these variants of concern. And also, I just want to touch on how viral genomics, that's the study of the genetic material of the virus, can contribute to COVID-19 mitigation and control efforts. So this panic, just so we're all on the same page, SARS-CoV-2, the virus that causes COVID-19, is now responsible for over 104 million COVID-19 cases, and that's reported cases, and almost 2.3 million deaths around the world. Here in Trinidad and Tobago, mandatory mask wearing and very strict border controls have allowed us to control and suppress our outbreak and maintain very low numbers of new cases in recent weeks. In total, as of yesterday, we had 7,612 confirmed cases and 135 deaths, as we heard from the minister. Now, when a virus is transmitted to a susceptible person, it enters their cells, and once it's in there, it replicates to produce millions more particles, millions more new viral particles. And during this process of copying, making these new virus particles, millions of copies of the virus genome are made. Now, every time, and those viral genomes are incorporated into the new virus particles, but every time the viral genome, that's the genetic material of the virus, is copied, every time that happens, you have the opportunity for errors to be made. And those errors are called mutations. Now, the genome, as I said, is a genetic material. It's like an instruction manual, and it contains all the information necessary to make and to maintain an organism. So this changing of the sequence of the instructions is actually the basis of evolution. And viruses have very high mutation rates, millions of times faster than humans. Now, most mutations that occur in a virus, they're deleterious, and the virus particle that contains that mutations, they don't survive. So you have all this mutation going on, but not all of it leads to a successful viral lineage. A large portion of them have absolutely no effect on the virus at all, and whether they survive in the population or not is just a matter of chance. And occasionally you get mutations that confer a fitness advantage over other viruses. And that's one of the things we've seen recently with these variants of concern. Now, as every time the virus passes from one person to another and it replicates in that person's body, it's another opportunity for evolution to occur. So that the longer the pandemic goes on, the more chances there are for evolution to produce variants that are better adapted than their predecessors to the current environment. Now, the genome of the virus is made up of these nucleotide bases, and we can call them letters. They make up so that you can read these letters by a process called genome sequencing. And since the beginning of the SARS-CoV-2 pandemic, scientists have been sequencing virus sampled from infected individuals and using models of evolution to reconstruct the sort of evolutionary history of the virus, as shown in this tree here. This is a phylogenetic tree. It's basically a family tree of the SARS-CoV-2 viruses that have been sampled over time. Now, the map on the right of this figure shows the global distribution of those lineages and the proportions of each lineage in different countries. So if we look here, when you start off with a pandemic, all the viruses infecting people are very similar, but over time, they diverge, branching out like a family tree, as I said, and some of the lineages die out, others persist. And you can see that the amount of diversity, the different colors that you have in the different countries, it changes over time, it increases over time. So you can use genome sequencing now to reconstruct the evolutionary history of a virus, but that's just the beginning of what you can do. There are a range of other questions that can be answered through genome sequencing. So first of all, you can use genome sequencing to identify a virus. You have an unknown virus, you sequence it, you can say what it's related to. This is exactly what happened with SARS-CoV-2. Then, due to the rapid mutation rate of the virus, if sequence data is combined with information on when and where the samples that the sequence came from were collected, you can also track the spread of the virus, and you can also infer from sequences, present-day sequences, you can infer when and where a particular lineage arose. As well as, if you have enough data, you can infer things like the rate at which the epidemic is growing by looking at that increase in diversity. Now, so if virus genome sequencing is undertaken rapidly and on a large scale, then it can assist epidemiologists and public health authorities in understanding how the virus is spreading and also in evaluating the effectiveness of their interventions. So you have an intervention, you want to see, is the virus growth rate, of the virus population growth rate slowing? And all that can be inferred from sequence data. It's also important to establish whether new variants are associated with particular patterns of disease or severity of disease. And now that we have several vaccines, we also want to track new variants. That's going to be very important to ensure that the vaccines remain up to date and able to neutralize the viruses that are in circulation. So coming to the project now, the COVID-19 Impact project, the aim of this project was to be able to introduce this capacity to Trinidad and Tobago. So as we heard, it is a UE-led project funded by the UWI Trinidad and Tobago Research Development Impact Fund, and it involves co-investigators from the Ministry of Health, CARPHA, the University of London, and the University of Oxford. And the aim of the project is to, because we've done that now, is to establish the local capacity for generation of SARS-CoV-2 whole genomes in order that viral genomics and related molecular epidemiological approaches can be incorporated into public health efforts. So the specific objectives were to implement this Oxford nanopore technology. It's a very cute little sequencing device that is very small, fits into your hand, it's portable, it's cheap, it's flexible. So to implement that technology and also these bioinformatic pipelines that are used to analyze the data, to implement all of that at the Faculty of Medical Sciences, and we did that in December. We also wanted to generate baseline data on SARS-CoV-2 lineages that have been circulated in the Caribbean through the sequencing, and most importantly, to respond to requests from public health bodies for answers to questions related to COVID-19 mitigation and control that could be answered by genome sequencing. Now, because of the speed and flexibility of the sequencing technology we have these days, the sequencing and the analysis, the project is able to generate real-time epidemiological information that is both interpretable and actionable by public health bodies. So this table, this table here shows just summarizes some of the work we've done so far. At the top row that you see, that shows all the different lineages of SARS-CoV-2 that we have identified in the Caribbean so far. And down the side on the left is a list of the Caribbean countries that have sent samples for us for sequencing. And the second row is the below the lineages, shows you where those lineages are most commonly found. Okay, so in all, we have generated sequences from RNA extracted from 165 SARS-CoV-2 infected individuals from 11 countries, 11 Caribbean countries. We've identified 28 different lineages to date. And for Trinidad, in particular, Trinidad and Tobago, we have sequenced, we have generated 89 sequences from 105 samples that we got and identified 9 different lineages. Now, amongst these lineages, you'll see I have one highlighted in red. That is B117, which people know as the UK variant. I'll talk about it a little more just now. And we detected that in 5 countries. In 2 of those countries, Barbados and St. Lucia, it was in the local population, and in the other 3, it was in travelers. And in the case of Trinidad and Jamaica, I believe it was a quarantined individual. So as far as we know, we have no evidence that it's in any local spread of it yet. So just to look at these variants of concern quickly. The first one is B117, as I said. And that was, as I said, was first detected in the UK. It's now been reported in 75 countries, and it's been shown to be at least 50 times more transmissible than other lineages. So it grows very quickly. If it enters a population, it's going to dominate the virus population. There was a recent report suggesting that it might be slightly more deadly, but that is still to be confirmed. And there's some there's been research that doesn't show the same thing. So that's not confirmed yet. There's no evidence of any significant immune escape, or all they see is there's partial, very slight vaccine efficacy reduction. So this one the vaccine doesn't seem to be a problem. We then have B1351, which is the one that first emerged in South Africa. And this one is of concern because there's evidence of some immune escape or partial vaccine reduction. And it's not clear yet if it is inherently more transmissible. The last one is P1, which was first detected in Brazil, reported in 12 countries, and it also carries mutations that suggest that there's some level of immune escape. Important to note that they all are susceptible to the vaccine immunity. So the vaccine can protect against them. So the vaccine is is very important, even more important, because we don't want these less sensitive ones to dominate. Okay, so just to complete the COVID-19 Impact project, what we've done is we have built capacity to carry out genomics sequencing in the Caribbean. And the advantages of that is that we can have improved SARS-CoV-2 surveillance and control, improved understanding of the epidemiology of the virus, and also, very importantly, incorporation of sequence data from Trinidad and Tobago and the wider Caribbean into global data sets so that we are incorporated into the research that's going on worldwide. Of course, this type of work can have impact beyond SARS-CoV-2. You can apply this to future emerging diseases in humans, animals, or plants. You can apply sequencing approaches to study of existing diseases of public health concern or of agricultural importance, and also for things like tracking antibiotic resistance in the population. And just to end, I just want to thank all the people who have been involved. Now, all the names here are the people who are involved in the project. I've highlighted in bold those people who were involved in generating the data that I spoke of so far. And in particular, I have to mention Dr. Nikita Sahadeo, who has been working night and day since before Christmas, all through Christmas, to get this work done. She implemented she implemented the whole system and has been working on the analysis, etc. So I just want to mention her. Thank you very much.
Thank you, Professor Carrington. The next presentation is entitled Vaccine Development and Approval, Safety and Efficacy. The presenter is Dr. Carla Alexander, who lectures immunology to undergrads and postgrads at the UWI St. Augustine campus. Her interest in immunology began while studying medical laboratory technology at the associate degree. After completing her undergraduate studies at Howard University, she received a doctorate in immunology at the University of Iowa. Following a postdoctoral fellowship at the University of Colorado, she returned home, working as at a medical laboratory and teaching at Costard. Her interests include autoimmunity, transplantation, and the use of flow cytometry in immunological studies. Dr. Alexander?
Good afternoon, all protocols observed. I thank the organizers for inviting me here to speak today. So vaccines are responsible for giving protective immunity to a vaccinated individual in case they are exposed to that particular pathogen. And there are different types of vaccines as indicated on the slide that you see here. They can range from the component vaccines, which include the protein subunit, the DNA and RNA base, and the viral vectors, all the way to the whole vaccines, which would include those pathogens that have been either inactivated or attenuated. And the vaccines types that are in the purple circles are the ones that the COVID-19 vaccine platforms that are being used presently. Vaccines are made of various components. The main or the active component is the antigen or the pathogen that would cause the disease. But you also have other components, including your trace components, your antibiotics, and your stabilizers, and they all assist in making sure that that vaccine is a stable and viable product. So the number one question, if you ask anyone, is, are vaccines a safe product to be utilized? When someone has been immunized, they are usually monitored for what is called an AEFI, which is your adverse event following immunizations. And there are 5 different types of these. They range from your vaccine product related reaction. This is when an event occurs because of the vaccine itself, all the way down to a coincidental event. This is indicated when, per se, example, a fever has occurred coincidentally while the person has been vaccinated. So it's not that they got the fever because of the vaccine. They may have had a fever at the same time that they were being vaccinated. And if we look at the vaccine product related reaction, this comes back to the fact that any vaccine component may cause an AEFI. A real-world example would be with respect to the COVID-19 vaccines. There are persons who are allergic to a compound called polysorbate. Now, polysorbate is found in everyday products, example, cosmetics, vitamins, and supplements. Polysorbate itself is closely related to PEG, which is polyethylene glycol. This is important because this is a component that has been used in your Moderna and Pfizer vaccines. So persons who have the allergic reaction to polysorbate may also have an allergic-like reaction to the PEG in these vaccines. To ensure the safety of vaccines, they undergo a very rigorous testing process. It begins at the preclinical trial stage, where the vaccines are themselves tested in research animals. It then proceeds through different phases, phase 1, phase 2, and phase 3, whereby you have increasing tests being done on the vaccine. You also have increase in the sample size of the individuals who are vaccinated, and you also increase the demographics, the different groups of individuals that are vaccinated. They then reach to the submission stage, whereby it is the vaccine product is given to a regulatory board to receive permission for general public use. It does not stop there, however. Even after introduction to the general public is occurring, you have phase 4 occurring, whereby clinical trials are continuing, AEFIs are being studied, and different timings and doses are then being implemented. Basically, you're just trying to make sure that the best vaccine is being utilized in the general public. Now, a comment that I have heard, and I'm sure everyone here has also heard, is how is it that these COVID-19 vaccines were developed so quickly, especially when we were told that it normally takes about 4 to 10 years for a vaccine to go from idea to production? And there are many factors that contributed to this, especially since SARS-CoV-2 caused such a worldwide pandemic. Many of the governments of the world then placed their financial resources towards making this vaccine as quickly as possible. What should also be noted is that previous research had been done on coronavirus before SARS-CoV-2 became a pandemic. So scientific researchers were able to utilize what was there before to quickly develop your COVID-19 vaccines. Also, what should also be noted is that there was free exchange of scientific information among researchers and scientists, allowing everyone to be collaborative and working together quickly to try and diminish this pandemic. So this table is showing the 11 vaccines for COVID-19 that have been approved thus far in at least one country. I've included a 12th vaccine, the Johnson & Johnson, also known as the Johnson vaccine, because they released some interim preliminary clinical 3 results that were very promising, and in fact, that company has started to apply for emergency use authorization in the United States of America. So we have looked at, oops, my apologies. We are talking about safety here, and with respect to some of the vaccine, the COVID-19 vaccines that have already been released, what has been seen is that there are various side effects, as in pain, fatigue, headache, etc. But they slowly, they're quickly eased in the individuals. There have been some anaphylaxis reactions, but what has been seen is that the majority of them occurred within the first 15 minutes of injection into that individual. And everyone who had an anaphylaxis reaction recovered. So that is very good news. So we have established that vaccines are safe, but the other part of the story is, are they effective? What is the efficacy of these vaccines that have been produced? And I just want to emphasize here the difference between efficacy and effectiveness. Now, efficacy is looking at the percentage reduction of a disease in a group of vaccinated persons in a clinical trial, while effectiveness is looking at it in a real-world situation. You are looking at how well the vaccine works once it is given to the community outside a clinical trial. With respect to efficacy, what we should remember was that in 2020, the FDA stated that for any COVID-19 vaccines produced, they needed at least a 50% efficacy to be effective in the general population. And the good news is that the majority of the vaccines that have been approved are above that 50% efficacy that was being requested. We also note that in the clinical trials, there was a racial diversity among the individuals. And this is especially important with respect to our multi-ethnic population in Trinidad and Tobago. So it's not only that the vaccines are working, but the efficacy in the clinical trials were collated from individuals of diverse ethnicities. Now, remember I talked about efficacy and effectiveness is within the community. Because the country of Israel has such a specific immunization program, and they were able to immunize especially so many of their over 65 age group, we were able to get data that are showing a real world situation. So now we're actually seeing effectiveness of the COVID-19 vaccines. And as you can see here, less than 1% of the individuals who received both doses of their vaccine came back with an infection. That is therefore suggesting that these vaccines are very effective in the outside community. As Professor Carrington has already mentioned, we are worried about the presence of variants to these vaccines. And she did identify the 3 different ones, the UK, the South African, and the Brazilian one. But we should not lose hope because early studies are showing that these vaccines still have some efficacy against these variants. And it should also be noted that research has not stopped with respect to these vaccines, and they're in fact tweaking the vaccine to see if they can then fight specifically against the variants that have been produced so far. So what is next? My apologies. What is next? Well, obviously, continuous vaccination worldwide needs to continue. And this is especially important when we are talking about the emergence of the new variants. If we continue with the vaccination worldwide, we diminish the chances that the viruses have to survive and then also mutate to have new variants emerging for us to then try and fight. At this stage, we spoke about the 11 vaccines that have already been given approval, but there are at least 70 other vaccines that are in various stages of development. So it does look good for more vaccines to be produced, which is only encouraging news, as that means it will be a faster rate of vaccination worldwide. And it should be noted that Oxford, in continuing their research studies, have come up with an idea of testing if you can mix the different vaccines that are presently available. So this clinical study is going to look at if you give an individual one dose of one particular vaccine, and then when that individual comes back for a second dose, they will get another dose of another vaccine. For example, the Oxford first and then the Pfizer second. And they wish to see if this increases the immunity given by the vaccines in individuals. I thank you for your attention.
Thank you, Dr. Alexander, for your excellent presentation. The next presentation is entitled COVAX Facility, COVID-19 Vaccine Distribution. It will be presented by the PAHO WHO representative, Dr. Erica Wheeler. Dr. Wheeler has worked in public health for over 27 years. She has been at PAHO and WHO at the global, sub-regional, and country levels. In a role in WHO headquarters in Geneva and in Asia for 17 years, she conducted research in a number of areas in public health policy and mental health, as well as leading the global portfolio for human resources for health in training and policy development, and coordinating guideline development for doctors, nurses, midwives, and allied health professionals in WHO Geneva. She has led, planned, and executed and established several programs and training at the country level in Africa and Asia for care and treatment of the mentally ill. In a recent post since leaving WHO Geneva as sub-regional advisor for the Caribbean, she has led the program of work with sole responsibility for country and sub-regional programs of work, which encompass capacity building, policy making, and planning for the whole range of healthcare workers and allied health professionals, which included working with sub-regional entities such as CARICOM. In her current post as country representative, she is responsible for all programs of work of PAHO WHO, which carries legal, managerial, and technical responsibilities. Dr. Wheeler?
Good afternoon, everyone. I would like to follow all established protocols. I want to start by thanking everyone for their interest in the work on vaccines, which is really critical for passing this first acute stage of the pandemic. So my presentation will go through three main areas: an update on the COVAX facility. Lots of people are now interested in what it is and what role it plays in vaccine development, looking at objectives, progress, and upcoming timelines. The vaccine strategies and rollout, what are the COVAX responsibilities, country responsibilities, and then the next steps. So what is the COVAX facility? Well, it was set up to support the largest actively managed portfolio of vaccine candidates globally. It's the first of its kind in the world. And it is meant to deliver 2 billion doses by the end of this year. And as a matter of fact, it now has secured 3 billion doses. To offer also a compelling return on investment by delivering COVID-19 vaccines as quickly as possible. And we have seen from the previous speaker that, yes, we already have several vaccine candidates to guarantee fair and equitable access to COVID-19 vaccines for all participants and to end the acute phase of the pandemic by the end of 2021. So following on from that, it is a coordinated mechanism to provide equitable access, risk pooling, and the risk pooling is important because several countries around the world have put money into COVAX, but so has the participating countries who are receiving vaccines. And it is meant to do it using affordable options for all participating countries. So the idea behind COVAX is getting vaccines in bulk leads to a reduction in the price. It is led by Gavi, which is the vaccine alliance that's been around for a few decades, and they traditionally provide vaccines to some of the poorest countries of the world at no cost. Also, the Coalition for Epidemic Preparedness and Innovations, which is an alliance to finance and coordinate the development of new vaccines. It's called CEPI, and of course, WHO. And since PAHO is a part of WHO, we are part of it as well. So the Gavi is the COVAX facility administrator, and as such is responsible for making the investments across a broad portfolio of promising vaccine candidates, which you saw in the last presentation. And to date, we know that 9 vaccines are part of the COVAX portfolio, and there have been as many as 172 countries, well, more now, it's now 192 actually, that have expressed interest in participating in the mechanism. So as I said, this is quite innovative. It's something that's been done for the first time ever. So in terms of progress on agreements with suppliers, we see here we have the Serum Institute of India, AstraZeneca, Oxford, Janssen, and Sanofi. And the Serum Institute of India will give the advanced market economy countries, that's what advanced market countries, these 92 countries, access to vaccines, licensed from Novavax and AstraZeneca and more as it goes on. And why I mention this is that some of these countries are within the PAHO region and within also the Caribbean, that they will be receiving vaccines free of cost. And the facility then does this coordination through these bodies that I previously mentioned, CEPI, WHO, and Gavi. And they've signed several deals with the manufacturers. So what is this vaccination strategy? Well, the 2 main goals of vaccination program are inextricably linked: to improve individual as well as public health. Remember, I mentioned ending the acute phase of the pandemic by the end of this year, 2021, but also to minimize societal and economic impact, because at market price, some of these vaccines will be unaffordable to many countries. And of course, to significantly reduce the impacts of COVID-19 in the safest, quickest, and most effective way, it is not necessary to vaccinate the whole population, but we know that there is such a thing as herd immunity, but the aim of COVAX is to vaccinate in the first phase at least 20% of the population of a country. Okay, so there are three components that inform the formulation of vaccine strategies. The first is something called the allocation framework. It sets the frame for overarching public health goals and priorities. And this looks at the 3% of health workers in a country, for example, that should be given the vaccine in order to protect them because they are the most vulnerable. And then the remaining 70% in the first phase, such as persons who are elderly and those who have underlying health conditions such as non-communicable diseases. The second strategy that's set up by SAGE is the Strategic Advisory Group of Experts, and this is for WHO. There is another SAGE that operates in the UK, but this is the one that advises WHO. And they provide guidance and policy advice in the context of the specific candidates. Then this is the vaccine candidates, okay, for the vaccine strategies. So when we say that Trinidad and Tobago is receiving AstraZeneca, somewhere else is receiving Pfizer, it is based on this coordination between the three entities and the decisions looking at the epidemiological profile of countries to say which countries should receive which vaccines. The third arm of this is regulatory and looks at safety and also monitoring. So it provides guidance on regulatory issues, safety and monitoring, both for candidate vaccines, the specific candidate vaccines, and system-specific approaches. So this global allocation framework secures fair, equitable, and necessary access to vaccines. The goal is to reduce COVID-19 mortality and protect health systems. And this is important. We don't talk enough about it. Protecting health systems. It sounds very airy-fairy, but it is everything that makes health services work in a country. And if you don't have strong surveillance mechanisms, for example, you don't have a good view of what is going on locally. So we must not forget that health systems are critical to supporting the vaccine rollout. So one of the goals, therefore, is reducing COVID-19 mortality, protecting health systems, which will significantly improve the well-being of the population and reduce the impact of the pandemic on societies. These goals in the context of scarce supply leads to prioritization of specific population groups that I mentioned just now. These could include health, social care workers, older adults, and others with high-risk conditions. And the timing, given the status of the pandemic, and initial allocation should be received by all as products become available. So I say a bit here that as products become available, right now, we saw the list of candidate vaccines, but thus far, WHO has approved Pfizer and they're about to approve AstraZeneca. Why? Because WHO approves vaccines for the entire world. We have stringent regulatory authorities in the USA, Canada, Europe, but WHO follows mostly the European regulatory authority. It takes all others into consideration, but you must remember that they provide a review of safety, quality, and efficacy for 194 member states. So, sorry, that was a bit of a jump there. So the kovacs facility here, this is just to show you who's included in it, but it looks at all issues. When we are talking about vaccine rollout, we're talking about communication, advocacy, training, data and monitoring, coordination, implementation and guidance. It is not just it's not a vertical program. It is integrated into health systems. So we have a health systems approach while we are looking at our vaccine strategy. So we look at the introduction of the vaccine, the demand, as well as supply and logistics. And for this, supply and logistics is going to be critical. And this WHO Strategic Advisory Group that advises on vaccines, it gives recommendations about how they should be used, with what age groups they should be used. Those are detailed recommendations that would come out once the AstraZeneca vaccine will be approved, and the stated date is the 15th of February. So these are some of the things. I wouldn't go through them in detail because of time, but just to say that this advisory group provides guidance to WHO, which is then implemented globally by countries. So just to mention how Trinidad and Tobago and all the other countries of PAHO will be receiving their vaccines, it will be through the revolving fund. So the COVAX facility has a relationship with the revolving fund for vaccines, which has been around in PAHO for the last 40 odd years. It's a platform to ensure access to vaccines for the region, and it is the largest pool procurement mechanism in the world for the self-financing countries, of which Trinidad and Tobago is one. And you see, it works alongside the National Immunization Program for the Americas. So there is an established fund that will provide the support and the logistics for Trinidad and Tobago. And the strategic priorities here for COVAX, the rapid scale up and the delivery of the more than 2 billion doses to bolster research and development, products and regulatory pathways, and to ensure 3 robust lines of defense against the virus and variants that we've been talking about, and to stimulate rapid update of test therapeutics and PPE. So we don't only deal with vaccines, we deal with a whole range of other things. And the country responsibility, I'm not going to read all of this because of course it's too much, but what I want you to look at, and I'm not sure does this help? Yes, it does. These are the country responsibilities here that Trinidad and Tobago has been working on. It's called the VRAT, the Vaccine Readiness Tool, planning and coordination, resources and funding, regulatory aspects, service delivery, training and supervision, surveillance and monitoring, vaccine logistics and the cold chain, safety and surveillance, and advocacy and mobilization. So this is really quite critical, and this is something that Trinidad and Tobago has been working assiduously on, and I really have to thank the minister here for his leadership in driving this forward. So this just shows you the specific vaccination delivery approaches that are defined for the different target groups that I mentioned previously. So it re-emphasizes this is global. This is not just Trinidad and Tobago. And Trinidad and Tobago is following global protocols in the rollout of the vaccines. The COVAX facility conveys information to us through WHO. WHO conveys it to PAHO, and we work with the countries to implement it. So there is a standard that is followed globally. And I just wanted to show you this because these are some of the things that are looked at when deciding on the distribution of vaccines, because I said these are country responsibilities, and you could see here Trinidad and Tobago is prepared for the cold chain storage. So they're showing their readiness in the preparation for the introduction of the vaccines, which of course is critical. So what are the next steps? I just have a couple of slides here. The next steps, all respondents to the expression of interest are considered, and manufacturers have to submit their data. WHO cannot do anything until the manufacturers, that you see that long list there, people would think, well, why doesn't WHO approve more vaccines? Well, we can't approve it unless there are expressions of interest from the manufacturer. And the manufacturers, Pfizer and AstraZeneca, have submitted their expressions of interest, and they're being reviewed. The priority is given to those who have not started vaccination. This is in terms of the receipt of vaccines. Those who have met the readiness criteria, but I just showed you the VRAT, and those who have opted into the price. There are 2 different mechanisms to opt in. It's grouped by the WHO region. That's one of the criteria, and each group is ranked by risk of the health worker exposure. So high mortality equals high exposure. And fifthly, the participants are selected from each group to a maximum of 18 for the Pfizer quantities. Why? Because there's a global shortage of Pfizer vaccines, okay? So the decision for Trinidad and Tobago to have AstraZeneca rather than Pfizer, it has nothing to do with safety efficacy. It has to do with the fact that the profile of Trinidad and Tobago and all the other countries have been reviewed, and those who have high mortality, high exposure by health workers have been given Pfizer. Trinidad and Tobago's readiness is such that they feel that Trinidad and Tobago can cope, and Trinidad and Tobago has a much, much, much lower mortality, and we are receiving AstraZeneca, and it has nothing to do with one being better than the other. Okay, the strategy is worked out globally. And this is my last one, key areas for the vaccine deployment. You see, it's the regulatory authorization process, having things in place for the importation, for the release of the vaccines, and then for post-introduction surveillance. Because once the vaccines are received, there has to be follow-up, because remember, it's for emergency use during the first year. And just want to say on this that there's been a lot of controversy. There's my last slide about the COVAX facility, but it is a global effort. We have never done this before. And countries, the COVAX facility always knew that countries would have bilateral deals. But we know that this is something that has to be done by countries in the world. And in terms of introducing vaccines, we know that there will be competition, but the idea behind this is to make sure that everyone gets vaccines fairly and within a short period of time. So I want to thank you for your attention.
Thank you very much, Dr. Wheeler. The next presentation is the next presentation is along similar lines. It will be presented by the CMO, Dr. Roshan Parasram. The title of that presentation is the Ministry of Health's Readiness to Receive and Distribute the COVID-19 Vaccine. Dr. Parasram is a physician and public health consultant working as the Chief Medical Officer of Trinidad and Tobago. In his capacity as CMO, he is the national focal point as it relates to the international health regulations, including the Quarantine Authority for Trinidad and Tobago. Accordingly, he is the chairman of the multi-sectoral committee to treat with COVID-19 and any emerging infectious diseases. He completed his MBBS here at UWI St. Augustine campus. This was followed by a postgraduate diploma and a MPH at the London School of Hygiene and Tropical Medicine, University of London. He also has a certificate in public procurement law and practice from the University of York in Canada. He's also a fellow of the Royal Society of Public Health in London. CMO, please.
Thank you, Professor Simeon. All protocols observed. So my presentation will lead off from where Dr. Wheeler left us. It will go through a little bit of pre-arrival, arrival, storage, and dissemination of vaccines in Trinidad and Tobago, and our readiness to do so. So it looks at the Ministry of Health's preparedness and to receive and distribute. So starting off where she left off with the COVAX facility, the Ministry of Health has been taking a three-pronged approach to securing the COVID-19 vaccines. So looking at the COVAX, I won't go back into detail, but as of the 30th of January, TNT was allocated an initial 100,000 to 120,000 doses of AstraZeneca via the COVAX facility. We are also having bilateral discussions since October 1st of 2020 with Pfizer, AstraZeneca, Sinopharm, Moderna, and Sanofi. The use of a CARICOM initiative where Trinidad and Tobago is registered as a purchaser of vaccines by the African Medicine Council. We have been allocated or pre-allocated 226,000 doses so far. By way of our planning, so in terms of pre-planning for vaccine arrival, the normal process, and just to touch on a little bit of the behind-the-scenes work that goes on, official requests to PAHO for vaccines via the Office of the CMO, MOH acceptance of price estimates, and to provide evidence of PAHO payment, and that is usually done by wire transfer, pre-alert and shipping, and followed by manufacturer, distribution, dispatches, and vaccines to the country or the consignee. The consignee for Trinidad and Tobago usually comes out of NIFDEC, out of C40. Again, when the vaccines do arrive, there's a process that has been tried and tested in Trinidad for quite a long time, We have vaccine transportation from the site. Usually it goes to C40 in normal circumstances. In this instance, there may be some alternate sites based on the vaccine that we do get. Brokers and custom clearance are part of the package, as well as brokerage alerted pre-arrival as well. So in terms of the vaccines, and when we look at the vaccines, we didn't know which vaccine we were going to get in the early days. So we had to plan along different tracks as it related to storage of the vaccines. So we didn't know we were going to get the AstraZeneca, which is 2 to 8 degrees. We didn't know if we were going to get Moderna, which is -20. We didn't know if we were going to get Pfizer, which is -70. So they require some different storage techniques and some different distribution techniques as well. So AstraZeneca, as it may have it, is our first vaccine, seems to be our first vaccine that we will get. It's given in 2 doses. Initially, it was recommended that these doses should be given more or less 3 to 4 weeks apart. And we have seen with recent research that it suggests that this vaccine should really be held beyond 6 weeks after you get the first dose, and that's based on the efficacy we are seeing. We're actually seeing it being noted that it should be given 3 months after the initial dose, and that has to be borne in mind. For example, if we do get 100,000 doses, it means that we will have to vaccinate 50,000 persons with 2 doses. What that means, and we take the expiry into account as well, our expiry is going to be somewhere between 5 months and 6 months. So it means that in the first 2 months, we have to vaccinate 50,000 people, hold the other 50,000 for an additional 3 months, and use it up within the space of 1 month before it expires. So it creates a logistic challenge based on what we get. Right. So when we get different types, we'll have to change accordingly, and we have put plans in place to do so. So this is again 2 to 8 degrees C, NIPDEC C40 with a capacity of 120,000 doses storage at present. Arima General Hospital, another 120,000 doses. At the Point Fortin Hospital, a capacity of 100,000 doses. And we are building a chiller at the Couva Hospital and multi-training facility to house 400,000 vaccines. In terms of the facilities going beyond 2 to 8, so we have 2 to 8, a total of 390,000 doses to be stored at present. There are also, in addition, there are 100 plus health centers which have some capacity if we upscale. And of course, 2 to 8 is something very akin to a normal refrigerator. The storage can be done by either purchasing those refrigerators or outsourcing through other entities in terms of payment. So with regards to our ultra low, we have -20 with a capacity of 1 million doses with some assistance from the Caribbean Public Health Agency. 4 ultra lows, giving us a total capacity of 450,000 doses at present. Additionally, identified designated COVID-19 facilities currently have the capacity to store at 2 to 8 degrees. Okay, so just not going forward. So as we wait for this to respond, we have storage at the vaccination facilities, and again, the plan. Appropriate temperature and refrigeration specifically designated for vaccines only, secured location with authorized access, storage and usage based on expiry dates, as I discussed in the example, and vaccine refrigerator temperatures to be recorded twice daily. If there are temperature excursions, which have happened in the past, usually what happens is the manufacturer needs to be contacted. You need to say exactly how the excursions occurred, and of course, they will give you guidance as to if the vaccine remains viable thereafter. Initial distribution, again, initial distribution will be through our existing mechanism, which is through the RHAs. We have established 23 odd sites at the health centers. Not that the other sites cannot distribute, but we are looking at securing the vaccine, both in terms of safety and of course, monitoring and evaluation as we go forward. So we took a portion of the 100 sites down to 23 to make sure that we are doing everything right in the first instance. Distribution of the vaccines designated for the pathway, again, through the EPI program, through the District Health Visitors Program. And just in terms of our distribution capacity, last year alone, normally we have in our health centers the capacity to distribute vaccines on 1 or 2 days per week as a normal run. Last year, we would have distributed 444,555 vaccines for 2020 alone, giving almost under 500,000, and that's just using 1 day or 2 days. Our health centers, as they stand over 100 health centers, can distribute easily 15,000 to 20,000 vaccines a week, which will give us close, if we ramp that up using mass vaccination sites, we can easily get to 1 million doses in less than a year. So again, our phases of distribution, phase 1, healthcare workers, and healthcare would be the first group of people to get it. The minister calls it phase 1A. So 60 and over, persons with non-communicable diseases and essential workers, which include, but are not limited to teachers, police, fire service, defense force, sanitation workers, and airline staff. Phase 2 will be everyone else that can actually have the vaccine. We have seen for certain vaccines that it can be given to persons less than 16, persons less than 18. Pregnancy, WHO has recommended for Pfizer based on their conditions that you can't use Pfizer during pregnancy at this point. It may change as we get more research coming in. Administration, again, the Ministry of Health advanced in its preparedness. We can receive and distribute vaccines today or tomorrow if we do get it. We are in a position to do so, especially the AstraZeneca vaccine, which we have capacity, and we have been using 2 to 8 vaccines for a number of years. Necessary consumables, for want of a nail, the war can be lost. So we have to look at all elements. We looked at of course, we have a stockpile of 1 million alcohol swabs, 1.5 million syringes already in stock. We have vaccines and we have no syringes, no one can get a vaccine. So we have to make sure that we plan for every eventuality. Health visitors and registered nurses are also being trained, and of course the ministry is hiring additional staff to staff the 23 centers in the first instance to ensure that we don't utilize the existing staff in that regard. So we have excess capacity. COVID-19 vaccination is not mandatory, and it is something that we need, and I think this symposium will help us going forward in terms of that voluntary nature of vaccination. We need everyone to come forward, our healthcare workers, starting with our healthcare workers to be vaccinated. The use of a public-private partnership, and as we speak about different types of vaccines, we have the Pfizer vaccine, which, because of the way it needs to be stored at -70, it has to be stored, and when it is stored, it can only last for 5 days. So in terms of speed of distribution, and we have seen the US set up about 600 sites to do so for 300 million people. If we are to utilize all our health facilities, we can have 120 sites easily, if need be, for a much, much smaller population of 1 million versus 300 million. So our sites are great. We are looking at possibly 4 major mass vaccination sites in the event that we do get the Pfizer vaccine, so we can distribute it quickly to avoid loss through expired time. With regards to the Moderna, again, -20 at the back end. However, it gives us a little more time because you can actually take it off of the thawed environment and it goes 2 to 8 for 30 days, which is more or less very simple in terms of the vaccination distribution strategy. Again, 23 public health facilities are the initial plan with 4 mass vaccination sites. Just to end with a word on monitoring and evaluation. So the monitoring and evaluation is planned to be done utilizing telemedicine as well as utilizing an ICT base to track the vaccines and ensure accountability. We're utilizing data entry clerks who will be hired for all 23 sites in the first instance as an additional staff to enter when you have been vaccinated. Most of the vaccines outside of the Johnson & Johnson require 2 doses. So we have to follow those people in time for 1, to come back in for your vaccination, and for, of course, looking for adverse events and tracking those and reporting to WHO as the need be. With regards to benefits of the ICT system, we see databases of patients for vaccine uptake, and we already have a database of everyone from the CEDAR program in place. So we can have those people call beforehand to find out if they have histories of allergies and those kinds of things, and when they will be available to be vaccinated. Increase accountability, reduction of wastage, ensure theft reduction, and again, we will have Defense Force assisting us at the sites from the airport to central stores and at each of the sites to ensure that there's safety for the vaccines. Through telemedicine, we have a telemedicine platform that was established during COVID-19 to follow patients who would have been in the community, and that will be utilized again to track persons for their second dose. Adverse reactions will be reported on the ICT platform and is part of the monitoring and evaluation that will go forward. My last slide. So you can lead a horse to water, but you can't make it drink. I can assure you that Trinidad and Tobago is ready to receive the vaccine, that we are ready to distribute the vaccine, that we're ready to store the vaccine. Where we need the help of the healthcare workers and the help of the population is to get us, as Minister said, we need to get everyone to come forward, take the vaccine, get us to a place where we want to be, which is herd immunity, as quickly as we can. And then we can move forward into 2021 and 2022 in a much better place than 2020 was. Thank you, Professor Simeon.
Thank you, CMO, for that very timely presentation in which you address the distribution plans that you have, which are, of course, well advanced. At this stage, we move into the question and answer session. We'll start with the in-house participants. There are microphones in the corridors. Of course, you should ensure that there is social distancing, so you can ask questions to any of the 4 panel, presenters. So please ask your questions. For persons online, you can ask questions in either of 2 ways. You can choose to type your questions in the chat facility in Zoom, or you can raise your hands and ask the question. Okay, I'm seeing Dr. Khan. Yes, please.
Hi,
First question.
This is a question to Dr. Parasram. Dr. Parasram, if somebody has a positive PCR test and a positive antigen test, why vaccinate? Or should we start by checking their PCR testing and antigen testing prior to vaccination and give those who are negative the vaccine?
Right, I think the immunologist might be in a better position to answer that, but I think Professor Montai would have answered it. Generally speaking, what we know of vaccination and what I've learned from her is that after you have infection, active infection, there is an antibody response and there's an immunologic response. How long it lasts, most of the WHO advice has been that if someone has an infection, that we do look at vaccination possibly 6 months after the initial infection as a possibility, but they won't be a priority group to look at vaccination. I do, Professor Montai, you want to answer? Okay.
Please use the microphone because there are people online as well who are listening and would like to know.
Yes, that is actually the recommendation. What is happening is that after vaccination, the antibody levels, because we're using anti-spike protein antibodies as the surrogate, if you wish, perfectly of a good response, and also the neutralization, they are much higher actually than convalescent plasma. And so they feel that vaccination is actually going to act as a booster to people who have had natural infection and probably give them a longer duration of protection after, but it's important that you should allow them to give them a few months after the acute infection before vaccinating them.
My question is this: you're going to vaccinate people, you're going to vaccinate them, but the people who you're vaccinating, you don't really know if they've been infected before versus those who have been not affected. Should it not be wise to do a PCR test or an antigen test prior to vaccination so you could determine exactly the length of time for the second booster if necessary?
What I would say to that is going to be a very expensive business. Most people would, okay, some people are asymptomatic, but a lot of people have had some symptoms. And the reality is that that's not being done anyway, actually. It is
just a thought.
No,
okay,
I think it's going to be rather expensive, actually.
Okay.
Thank you. Please identify yourself before you ask the question, please.
Dr. Radber, I'm excited to get my vaccine when that time comes as a healthcare worker. My question is to Dr. Wheeler. There's so many vaccine houses throughout the world and we're in a rush. Operation Warp Speed. So my question is more like an observation and a note for all of us in terms of the ethics and the scientific safeguards and also the environmental compliance for the manufacture of vaccines throughout the planet, is that the WHO has a huge, fantastic job to monitor all the situations because we need the vaccine. But I hope we don't destroy the planet in the end. That's my comment or question. Thank you.
Well, yes, of course, we are all concerned about the state of the planet, but no, there is no risk to that. You have to remember, many of the vaccine manufacturers were currently there anyway. It was a case of expanding the ability to produce more vaccines. And this is why at the beginning of the pandemic now, that there aren't enough vaccines for the whole world immediately. We also know that many of the richer countries bought up a lot of vaccines, but in the process, it was a matter of expansion rather than any destruction as such or any ecological problem. So the vaccine manufacturers, they were given money upfront to do their research and development and to expand their capacity within, you know, like Novavax and Pfizer and so on. All of those who already existed, they were just given the capacity financially to expand what they were already doing. And of course, WHO has, I would think, when you think of the amount of work that we have to do, we have hundreds of people in different parts of the world that go through all the information that's provided by the manufacturers to ensure that quality, safety, and efficacy without doing damage as such, as you say, because we are a health organization. Thank you. But thanks for your concern.
Students, dental students, medical students included in the initial phase of vaccination?
Yeah, so the essential workers and the frontline workers are very broad. We have to categorize it down to the micro level. But having said that, persons that are in the clinical setting will of course be considered high-risk persons. So the intent of the first phase is to look at the vulnerable population. So we can certainly include them as a group of healthcare workers if need be.
Just to point out that Dr. Smith is the director of the School of Dentistry, and we thank you for the use of your facility this afternoon, Dr. Smith. Yes. Yes.
First of all, congratulations on the symposium. I think it's very timely. Ministry of Health in WI. My question is really directed to hopefully what will be a rush for the vaccine based on the symposium, and therefore I know you've stated you have identified already you have a base, but can you give maybe a practical guide as to how patients who might fall into the category can access the vaccine?
Right. So in terms of getting the vaccines, our primary strategy for the NCD clinics will be to capture the ones that are already there. But having said that, we are in the process of, as I said, putting together a master list of persons, and the intent is to actually vaccinate those persons, call them before, possibly give them appointments, so we'll reach out to them. If someone does walk into a health facility and meets and belongs to one of those categories, of course, they won't be turned away, they will be part of it as well. So the general advice is to, of course, look at the websites, continue to look at you can visit any of the health centers that have been so designated at COVID facilities. That list will come out as soon as or just before we get the vaccines in country. And of course, we will try to get to everyone in the high-risk groups in the phase one.
Thank you.
Through that mechanism.
Yeah, are there any other questions here in-house? Yes, please.
Hi, good afternoon, everybody. Nirad Tiwari from AmCham Trinidad and Tobago. Thank you very much for inviting the business community to be part of this symposium and for sharing the information. I think it'll do a lot. I'd like to make an offer to the Ministry of Health, first of all. I think what you've shared, Dr. Parashram, in terms of the rollout is very helpful, and we may be able to assist with regards to the communication strategy. And we would do so, of course, pro bono. So if you wish to avail yourself of those services, we would be happy to work with you and my colleagues in the other chambers as well. A suggestion, though, is to consider using the same technology or expanding the platform to do exactly what you were saying in response to the last question regarding the lists, so that you have people using apps or at the very least a database to put themselves down for the vaccine. So you have a sort of coalition of the willing at the very beginning, and you can use that to ensure that you don't have gaps, particularly for the Pfizer. If you're going to use 4 centers and you need to have the vaccines delivered within the 5 days.
Okay, thanks for the suggestion, and we'll take it on board. We're not going to use 4, if we get Pfizer, we're not going to use, just for clarification, we're not going to use 4 centers alone. 4 centers will boost our efforts. So we're going to use the 23 centers as our primary base. If there's need for speed or we get a large bulk of vaccines in a short duration of time, we will then need to use the mass vaccination sites, especially for Pfizer, because it has to be used up in such a short space of time. But it will be all the sites plus the 4. And we will certainly take your suggestions into consideration.
Yes, we have online participants. I'm not sure if there are any questions from the online participants.
Yes, we do.
Okay.
Going first to Adil Mohammed, the Faculty of Medical Sciences student representative.
Hi, good afternoon, everybody. So this was a question that would be more directed to Dr. Parasram. So Dr. Smith actually asked my initial question, which was if the medical sciences clinical students would be receiving the vaccine. Another question I had then, and this is maybe more of a suggestion, is that in the effectiveness of rolling out the vaccines to the nation and to the persons who would need it the most, we could probably train clinical medical sciences students in giving the vaccines, or at least helping out the current healthcare workers in delivering the vaccines to the nation. It's just a suggestion, but it was a thought that came.
Yeah, so it's definitely in consideration to use it. I know the dean is here, so we'll have to have some discussion. I just up to yesterday, we saw in other parts of the world, they have been using their medical students to deliver vaccines. So it's something we can consider here as well.
Hello.
Yes.
Yes, please.
Okay, now going to Jillian Wheeler.
Good afternoon to the panel. My question is for Dr. Parasram. Actually, 2 questions. One is, if we hold the vaccines, we immunize 50,000 persons and hold the vaccines to give them the second dose, is it that we would not be getting another batch before I think maybe 3 months? That's one. The second question is, well, okay, I'll leave it at one question. Thanks.
All right, thanks. So this was a scenario based on the initial tranche we were getting from the kovacs facility, using an example of 100,000 vaccines, which will bring you down to 50,000 people. In the meantime, we can, of course, get additional vaccines. We may get the Pfizer vaccine, for example. There's no research that suggests that we can use the Pfizer with the AstraZeneca first dose. So we will have to hold those AstraZeneca vaccines for those individuals. But the intent of pursuing 3 tracks for vaccines is that we're trying to get as many vaccines as we can, as quickly as we can. The 100 to 120,000 is just the first tranche of what we're getting from COVAX and elsewhere, and we hope to get more in the near future.
Okay, thank you. And actually, my other question was, would there be a registration process for persons interested in receiving the vaccine so that you have an idea of numbers?
Yeah, so there's the passive way that you could go in or be part of the facilities, and there's a pre-registration form that happens, but that happens real time with the nurses. But the master list we're trying to create, and again, the healthcare workers are on that list, and we have liaised with the RHAs to get a full list of healthcare workers. We have CDAP program over 60 on that list as well. So we've written to various ministries to get that detail. But that is our active going ahead, but there's also a passive way that people can come in. It will be advertised on the website, as I told Dr. Bodo, where you can get your vaccination in the coming weeks, as soon as we verify when our first shipment will be here and we finalize all arrangements with the sites.
Thank you.
Okay, the next online question. I cannot see the names, so I'm going to ask for assistance to identify who is the next person in line.
Can I ask a question?
Yes, please go ahead. I said I cannot
Okay.
see the name, but please identify yourself.
My name is Stuart Miller. I'm a general practitioner in Port of Spain. Are there any plans for using private GPs or other private in administering the vaccine?
Yeah, so what we have done so far in terms of the private sector, we have engaged the larger facilities to ensure that the healthcare workers are being given the vaccination, and of course TTMA in the first tranche. When we see how our vaccine supply is going and we see how the uptake is going, there may be through the Sentinel physician mechanism that has been set up for many, many years to give those physicians vaccines, and of course they will give us the M&E data that we need back for vaccination, but it won't necessarily be in the first early phase of vaccination.
Thank you.
Next, we go to Dr. Bahadur Singh. You can open your mic.
Good afternoon to everyone. Thanks for a lovely presentation today. My question...
¿Tiene alguna herramienta aquí, algún martillo o algo así? Sí.
You're hearing? My question...
Yo eso sí no tengo.
Yeah, please continue.
Good afternoon. Yes, my question pertains to persons with disability. So, for example, Down syndrome, cerebral palsy. So there's the adult population. I saw that on the CDC website, there's some priority given to adults with disability like Down syndrome, cerebral palsy. And I know the policy right now is not including children, but there are high-risk groups amongst children, the same population, cerebral palsy, Down syndrome, sickle cell disease, for example. So my question pertains to both kids and adults with disability and how our policy is going to handle those populations. Okay, thank you.
Yeah, so the first phase is designated towards our vulnerable population. Having NCDs and the like are categorized as being vulnerable. So certainly they will be part of the phase one. We want to show, of course, based on what has happened with Pfizer, that they are reviewed by their physician and possibly are given the green light before we go ahead and vaccinate. So there will be need for some review, but they will be part of the phase one as they are vulnerable.
Next, we have Rosanna.
Good afternoon to the panel. My name is Rosanna Pudam Robinson. I'm a district health visitor attached to Victoria North. I want to direct my question to Dr. Parasram with respect to the vaccine administration. And at first, I was not aware that we were getting different pharmaceutical preparation of the vaccine. I thought and I believe that we were only getting AstraZeneca. So my thing is with the rollout of the vaccines, and my question really is pertaining to the rolling out of the vaccines with AstraZeneca and not having to complete that process of the two administration to a client and then have Pfizer and the other type of pharmaceuticals in that setting when you have to give the other, the second dose. And, because every pharmaceutical preparation would be different, administration and different protocols and all that. So what I'm essentially asking is, how would we be able as healthcare providers to administer the vaccines when there might be a shortfall of the vaccine for that particular pharmaceutical, let's say AstraZeneca, where we have to give two, and Pfizer is the other one that is there to administer.
So it's just to try to untwist the question a little bit. So basically, we're looking at those persons that would have had the first dose of AstraZeneca need to have the second dose of AstraZeneca. Through the monitoring and evaluation framework, there's a form that would be filled out, and there's a data entry clerk at the point of vaccination that will have that information, and we will actively call those persons back in. So persons that had the first dose of AstraZeneca will be contacted and given a date to come back in. They will be by an appointment only. Those who need the other, if, for example, we have Pfizer in the system, other people can walk in and have Pfizer at that point in time, or even if we have enough doses of AstraZeneca where you could go beyond the initial 50,000, they can be offered either one of the two. I mean, as a district health visitor, you would be fully aware that we give many vaccines on a given day to many different people. We have MMR, you have yellow fever, you have tetanus, you have any amount of vaccines that you have and distribute to different persons. So I don't think having Pfizer and AstraZeneca to distribute will be a challenge for the district health visitors and the facilities going forward.
Okay, next we invite Maria Dillon-Remy.
Excellent presentations. Questions about monitoring. Given all the issues related to the people's questioning about the vaccines, what systems are in place? I know Dr. Parasuram talked about monitoring. What systems are in place for monitoring of side effects? Is it going to be an active or passive monitoring? And next, about antibody production in our population. How is there going to be any random checking of the persons who have been vaccinated to see how much, whether they're producing antibodies, and following up that, monitoring of persons who may get infected despite vaccinations?
So yeah, so everyone that is vaccinated will be on a database, which will be entered by the data entry clerk at the point of vaccination. And those persons will be followed in two ways, both passively by reporting to us through hopefully an app found at some point in the future, but more actively through the telemedicine initiative that was set up for COVID-19. So they will be called in the first instance, possibly every other day for the first week or so, just to make sure that they have no signs and symptoms suggestive of adverse reactions. And of course, the intent is to follow them up possibly up to between 6 months and a year through the telemedicine initiative to ensure that we are reporting any adverse events that occur later on. And of course, we are capturing if persons do get COVID-19 at the same point in time, that we will know that they would have been vaccinated and of course being positive thereafter. So our two main measures are really through the telemedicine initiative, having a full database of everyone that is vaccinated, and of course through an app that we are generating at this point that persons can use and report their signs and symptoms later on. Professor Carrington, you wanted to take any bit of that at the end?
No, I think what you've answered has covered it. I don't have anything to add to that. I think that's fine. Thanks.
Okay, thank you. Next, we invite Daniel Timothy.
Good afternoon, everyone. Thank you for providing this opportunity to educate us and to address the concerns of healthcare workers. I work in the occupational department in Northwest Regional Health Authority, and so far most of the questions that would have been collated have been addressed. What I'd like to find out is, seeing that there's no evidence really that the vaccine can completely stop the infection and transmission rate, is Trinidad and Tobago considering testing people, doing antibody testing for persons who've already been infected with the COVID-19 disease, and just seeing like what would be the concentration or how long the immunity would last naturally? And my other question would be, what are the warnings and precautions for the AstraZeneca vaccines, if any, seeing that Dr. Parasuram mentioned that with Pfizer vaccine, it's not recommended for the pregnant women? And if there are any warnings for people who, for example, suffer with severe allergies in taking the AstraZeneca?
Okay, so your second question about the AstraZeneca, so far they're in the process of doing the EUL, which is emergency use license by WHO. When that is complete, I think they have given a presumptive date of the 15th of February. they will put conditionalities to it, meaning that the reason I can say that about Pfizer is because WHO has reviewed it and given emergency use authorization for Pfizer, which lays out the conditions of use. So they have stipulated in that document from WHO that they can't be used for pregnancy and they can't be used for persons under a certain age. So, and amongst other things. So once that is completed on the 15th of February, we'll be able to tell you better for AstraZeneca in a similar vein what WHO recommends in terms of ages. Having said that, I think most of the vaccines would not have been tested on persons less than 16. So a lot of the recommendations may follow suit in terms of the vaccines out of WHO, that they should not be used in persons under 16. And of course, the pregnancy data similarly is very low. So again, they may have some restrictions in that regard. The first question regarding testing, we do have some WHO continues to recommend antibody testing for surveys. And I think it's a good opportunity that Trinidad look at the possibility of doing surveys in one, the unvaccinated population and the vaccinated population as we go forward. We do have some supplies. We still have, I think, 60,000 of the antibody test, which was donated by China, in stock. And it may be a good collaborative effort between the university and the ministry to look at antibody responses in Trinidad and Tobago using that supply. So it's a good suggestion.
I would like to point out that we'll have one more question at this time, and we have a stretch break. But for persons who haven't asked their questions as yet, please note that at the end of the next session, you will be able to ask your questions at that time. So one more question now, please.
Okay, I'd like to invite Keegan Bagan.
Hi, good afternoon, everyone. Thanks for the opportunity today first, and excellent presentation so far. My question really might not be, I'm not sure if it's relevant to the immediate tranche of vaccines that might come in, but what I'm wondering is there something in place for private institutions, such as the private companies that would normally bring in pharmaceuticals, to make their own negotiations to bring in vaccines as a separate supply from what the government would be planning to distribute?
Okay, so there's in Trinidad and Tobago, for a vaccine to be brought in, it has to be registered through the Food and Drug Agency, and you have to have certain conditionalities. This vaccine is the first vaccine I think that we have used in Trinidad under emergency use authorization. So it's different from other types of registration. So it is not really recommended at this point to go outside of the initial channels based on the emergency use authorization. So I would suggest that we stick within the public sector, and of course, any private arrangements that we do make as the government. And then later on, as the registration changes from emergency use to registration status, then we can go forward as we have done for other vaccines.
Okay, thank you. So we will take a 5-minute break now. I would like to request that all the persons who have logged on online to stay logged on, because we'll be rejoining, we'll be resuming very, very soon. So we just need to take a stretch break here at the School of Dentistry at the Eric Williams Medical Sciences Complex. Thank you. Okay, good afternoon again. We start the second session of the symposium, in which we'll have 3 presentations. The first presentation is entitled Acceptance and Public Attitudes of COVID-19 Vaccine in Trinidad and Tobago, to be presented by Dr. Sa, who is the head of the Center of Medical Sciences Education and Deputy Dean for Quality Assurance at the FMS at the UWI. Dr. Sa has an honors degree in education and a doctorate in 2004. He worked at the Addis Ababa University in Ethiopia before coming to the UWI in 2008. He has been the head of the CMSC, Center for Medical Sciences Education, since 2011, and Deputy Dean since 2018. He has a rich experience of more than 18 years engaging in faculty development programs, organizing and facilitating workshops and seminars, and is a prolific researcher and has published more than 50 papers in international journals in his area of interest, which is medical education. I would like to invite Dr. Sa to please do his presentation.
Thank you, Prof. And good afternoon, everyone. All protocol observed. So our presentation is more about public who really will get vaccinated. We attempt to study the pulse of the population. So the group of researchers listed here, you can see, from the St. Augustine and Caville campus, conducted a study on acceptance and attitude towards COVID-19 vaccine among the adult populations in Trinidad and Tobago. So as all we know by now that Ministry of Health is preparing to receive COVID vaccine and about to roll out. But acceptance is a great concern. One of the study recently conducted by Johns Hopkins University on the acceptance of COVID-19 vaccine in 67 countries, and luckily Trinidad and Tobago was included in that study. They conducted this study at 2 points of time, one in July 2020 and one in November 2020. In July survey, our Trinidad population, 51% say that they would like to accept a vaccine if one were available. However, it dropped down to 41% when the survey was conducted in November 2020. Thus, we thought of conducting a research which is really needed on COVID vaccine acceptance and attitude to maximize the vaccine uptake. So thus, the objectives of our research are outlined here to determine the vaccine acceptance and attitude in TNT, to identify factors associated with the willingness to take the vaccine, and to prepare recommendation to the Ministry of Health that can strengthen its pro-vaccination strategy. With those objectives, we developed the proposal and we got the ethical approval from our campus ethics committee, St. Augustine. Basically, it was an online cross-sectional survey which was conducted between the 27th of December 2020 to 11th of January 2021. And we adopted the snowball sampling approach. We approached our participants, those who are residing in Trinidad and Tobago, and those who are above 18 years of age, 18 and 18 above, through snowball sampling. And we developed one questionnaire which collected data on the different demographics, health status, if there is any vaccine history, and acceptance and attitude towards the COVID-19 vaccine. The results are here, that demographics. Finally, we are successfully able to collect the data from 1,101 respondents throughout the Trinidad and Tobago, out of which 54% were female, 87% of them belonging to the age group of 18 to 45 years, 68% were single, and out of that 66% were employed somehow. Going to the next question, we did ask direct question that whether would you agree to accept a vaccine that is approved by WHO? Then we see that 38% of the population say yes, and 62% of the population say no, which is in line with the findings of Johns Hopkins University and other global studies conducted across the world. Just to remind here that the Johns Hopkins University also included Jamaica in its study, and in that the Jamaican population in July survey 35% interested to take the vaccine, but it dropped down to again in November survey to 28%. So, and according to our study, we reported here 38% is ready to accept the vaccine and 62% not yet. So we asked them the reason for not accepting the vaccine. These 686 people, those who are consisting of our 62%. And out of that, most of the reason they are citing is they are worried about the safety of the vaccine, 46%. They are also waiting for that somebody should tell them it is effective, that is 22%. And the way the vaccine is rushed, the timeline, the production of the vaccine, and there is also a little bit of trust issues. Further, we asked about whether they have got vaccinated any influenza in the past, and we got the response here that 66% say no and 25% say yes. Now, going to the next slide here, we would like to focus here. Again, we did the further analysis, and the following variables were significantly associated with the acceptance of the COVID-19 vaccine. And as you can see that the age group above 55 years, 50%, and age group between 18 to 25 years, close to 50% again, they will be willing to take the vaccine. Mostly married people, single people are willing to take the vaccine, that is 41%. And those who are from the tertiary education, they are 42%. Again, when you talked about the employment status, mostly the students are interested to take the vaccine. And also, person who have got vaccinated with influenza vaccine previously, they are also willing to take the vaccine. Now, we did not find any significant effect of sex as a variable about the willingness to take the approved vaccine. And further, we try to find the attitude as we mentioned here. And you can see the similar percentage, they would like to take the vaccine. But again, you can see that they are worried about the side effect of the vaccine, that is 77%. And also, they would like to delay the vaccine until it is declared as safe, that is again 72%. And again, if you go further, that if it is mandatory to travel other countries, they would like to get it vaccinated, 66%. And further, if you move, that the population is concerned about the children and the children to get vaccinated before they go back to school. And also, if it is free, people are ready to take the vaccine. And if it is recommended by the job or the employer. One of the most concern we raised here about the last one here is that about 22% of our population, they have some mistrust about our health authorities. So we cannot leave them. We need to do some exercise. How can win their trust? This is the survey which is talking about. Now, following to this is the item I was talking about. So we need to do some more about to win their trust. Though it is a minor percentage. The next we did ask about some recommendation from the respondent themselves. What do you recommend to health authorities? How they should execute the vaccination program and all? We want to study the pulse of the population. So about 48.3% of that, though I should be very careful interpreting this finding here because not everybody responded to the open-ended questions. But for all the close-ended question, we reported 100% of the respondent responded to the questions. So these open-ended questions were responded by limited people. So they are of the opinion that health workers should be the first to receive the vaccination, followed by the vulnerable populations, and then the general population. Vaccination should be easily available, accessible in a safe and familiar and convenient locations like health centers. And they are also opinion that 8.9% of the people, it should be optional. And general knowledge and vaccine awareness campaigns should be launched by health authorities. Now, coming to the conclusion of my presentation, as we see that there is low rate of acceptability of the vaccine in the survey of the participant, but we don't have to worry about that because this is a thing, the attitude and belief, it can be changed. It changes over time with the education. So decisions related to acceptance of vaccines and decisions are actually, it is not one factor that contribute to it. It is very much multifactorial and it does change over time. To have an impact, man need to go beyond simply pronouncing that vaccines are safe and effective. We may have to do more about it. And vaccine communication strategy should consider that different subpopulation, how to convince them and identify locally trusted sources of information. With that, I conclude my presentation. Thank you very much for your patient hearing, and thank you. I would like to thank all my research group partners here for their hard work. Thank you so much.
Thank you, Dr. Sa, for that excellent presentation. The next presentation is entitled Overcoming Vaccine Skepticism and Hesitancy, Strategies to Optimize Uptake. The presenter is Dr. Daniel Solomon, who is joining us online from Harvard. Dr. Solomon is a clinical educator in the Infectious Disease Division at the Brigham and Women's Hospital, an instructor of medicine at Harvard Medical School. His clinical focus is on caring for patients with HIV, hepatitis C, and improving care at the intersection of infectious diseases and injection drug use. He's devoted to the care of underserved and vulnerable populations, and he's the Associate Director for Clinical Learning of the Health Sciences and Technology track at Harvard Medical School, and he directs the foundational clinical skills and communications course for preclinical students. Dr. Solomon, please.
Thank you so much. And hopefully you can hear me. If I could get a thumbs up, you can hear me.
Yes, we are hearing you loud and clear.
Beautiful, good. So thank you so much for the invitation to speak. I'm humbled to be invited and so impressed by your clear-minded and consistent mitigation response thus far and your thoughtful approach to a coordinated vaccination program. I've been invited to speak about overcoming vaccine skepticism and hesitancy with a particular focus on optimizing uptake in vulnerable groups. This is something I think about a lot in my own practice. I'm an infectious disease doctor in Boston, where I care for a lot of patients in poorer communities who have HIV and oftentimes substance use disorders, addictions. And so a lot of my patients face structural barriers to getting the vaccine, and then a lot of emotional barriers as well. You know, I want to state the obvious. In our country, There are some communities that have been hit harder by the COVID-19 pandemic than others, and vaccine hesitancy is higher in those populations. So we face the threat of an even wider health gap. And that's something that I care a lot about. The other thing that I'll say is that I'm going to be pitching this really to what you can do on the clinical level in the office or with your patients. I think there's a lot of public health messaging that's important. We just heard about that in Dr. Sa's presentation, but I'm going to be focusing on what you can do in your clinic. And that's, of course, going to be different than what I do in my clinic because our contexts are different. But I'm hoping to give you some strategies that may transcend culture. So let's start with a case just to put this in context. And we'll think about this as if you're practicing in Boston, but again, strategies will transcend. This is a 67-year-old Black woman who presents to clinic. She's eligible for the COVID vaccine, but she says she's not sure if she needs it. She does not get the yearly flu shot, just like we saw in the last presentation, and she's never had the flu. And she says she's been extremely careful with social distancing and mask wearing. In addition, she's nervous about how fast the COVID vaccine was developed, and she's concerned that pharmaceutical companies may just be trying to make money. And she asks, will it even work for people like me? So this is a short vignette, but there's actually a lot of nuance in here. And I'm going to sort of break down the different parts of vaccine hesitancy as we move along through practical tips, things that you might think about in your own practice. So we've got 7 tips here. The first is to do your best to make sure the vaccine is as convenient as possible for your patients. And I think about convenience as having 3 arms. Is it available? Is it affordable? And is it accessible? I'm going to tell you a story from my own practice. I have a patient who's eligible for the vaccine through our state program. In order to get that vaccine, she needs to log in online, so she needs an internet connection, go through a pharmacy and fill out a 2 to 3 page form to find out if she's eligible. If she is, she needs to log into a different website to book an appointment at that pharmacy. And if there are none available, start over at a different pharmacy. And if she does get an appointment, she needs to arrange transportation to that pharmacy in order to get the vaccine. There are too many barriers. I know that's never going to work for her. So we know that we need to set up alternative pathways for our patients who may not be able to overcome some of those barriers. So in our clinic, we're doing a lot of proactive outreach and bringing patients in for vaccines to try to make it as convenient as possible. Number 2, once we have the patients with us, I suggest that we assess where is our patient on the continuum of acceptance. I find this paradigm extremely useful. Oftentimes we think about vaccines as either I get it or I won't get it. And of course, there are people at these extremes, some people who will say, yeah, I'll get all my vaccines, and some anti-vax people who will say, I'll never get vaccines. But most people fall somewhere in the middle on this continuum, and understanding where they fall actually will help us tailor our advice and our messaging to each of those patients. So if you have patients closer to the right of this screen, that they are pretty much ready to accept, but they might just need a little nudge or a little bit more information, well, then we're just providing information. If we think about the vignette that I shared, I think that person is leaning away from the vaccine, but she has an open mind, so we might take a different approach with that patient. Okay, so we've said we know where our patient is on the continuum. Now, I think the most important part of my session here is to explore why they are where they are on the continuum. And I think this is fairly complex. And this requires a bit of a paradigm shift from how do I convince my patient to get the vaccine to I want to understand what your questions and concerns are. And I want to say here that I think we should think about listening first as a form of action. Listening accomplishes 2 goals, and I'm thinking about open-ended questions, non-judgmental, validating listening. The first goal is that listening is the foundation of trust. It sounds like trust is only a minor part of vaccine hesitancy in your country. It's a very big part of vaccine hesitancy in my country. So when we listen and validate people's concerns, we can change the paradigm of here's a vaccine I'm trying to push towards you to I'm actually going to ally with you and think about this as a shared decision. How can we make a decision that's in your best interest? Form that trust with the patient. The second thing that listening can do for us is allow us to tailor the information that we share based on what the patient's concerns are. And those are really all across the board. There are many different concerns that people have. The first thing that we might find is that individuals might think that the vaccine has very little value to them. You might hear things like, you know, the vaccine is probably not going to help me, or I'm not at very high risk of getting COVID, or there are just other things that are more important. When I think about our vulnerable populations, there's so many stressors that they face. And when we think about the hierarchy of needs, things they care the most about, some of my patients say, well, where am I going to get my next meal? How am I going to get my pain under control? Where am I going to sleep tonight? And those things are far more important than the COVID vaccine, which is much lower down on their list. So understanding, do you value this vaccine, allows us an entry point to help them shift the value and say, actually, the COVID vaccine is very important for you for these reasons. So how much does my patient value the vaccine? Then, of course, there's confidence in the vaccine. And I think this was laid out very nicely in the last presentation. Confidence is about how much do we trust the effectiveness and safety of vaccines. And baked into that is not only the vaccine itself, but how much do I trust the health services, health professionals, and the policymakers that are allowing this vaccine to be rolled out. When I think about confidence in vaccines, I think they fall into three big buckets: fears about safety, skepticism about the science, and then of course, religious objections. So understanding, you know, again, on that continuum, you're in the middle. Why are you in the middle? Is it about safety or effectiveness, or is it some sort of cultural belief that is stopping you from getting that vaccine right away? Okay, so that's confidence. Always have to understand confidence in the context of the situation we're living. So this is where I say my context is different from your context, but what are the roots of vaccine hesitancy in the United States for Black individuals? Well, there's a legacy of exploitation and medical experimentation. There are different cultural beliefs, racism, xenophobia. There are social and economic inequalities. We have this legacy of mass incarceration. So we can't start to address skepticism about the science without understanding some of the roots. Why do you have skepticism of the science? And I think you all are the best to understand those forces in your community. And I do think validation is important. You know, I think, and it helps with that alignment with patients. So here's some language you might use. Given the mistreatment that your group or Black Americans have faced, it makes sense that you might believe that doctors, hospitals, or the government aren't looking out for you. So it's understandable to be cautious and wonder if a new vaccine really works. Now the patient feels seen. They say, oh, this doctor actually understands. Now my ears are open. I'm ready to listen. Okay, so I spent a lot of time sort of listening and understanding where the patient comes from. Now we're going to transition to saying we actually need to share information and make recommendations. Before we do that, I suggest that you ask permission. Would it be okay if I share some information? It's a subtle point, but it engages the patient as an active participant in that information. It's not being pushed at them, it's being invited in. Then we share clear, consistent information. This vaccine is safe and it is effective. And I always recommend sharing stories more than data. The literature supports the use of stories as a sharing tool. Over 95% effective. I think patients really latch on to stories that you can share. So using language like, let me tell you about what I have seen, a family member, a colleague, those stories stick in people's minds. And when we're done sharing that information, always ask patients, what do you think about that? This is a strategy I call ask, tell, ask. So I'll show it to you in real time. Ask permission. It sounds as though you're unsure about whether the vaccine is right for you. Would it be okay if I share some information? Of course, the patient will say, okay, that's what I'm here for. Then we give our clear, consistent information. I tell a story about a patient that I've cared for. And then I ask again, what do you think about that information? What additional questions do you have for me? So that's how I try to engage with patients, ally with them, and share that clear information that I think they need in order to move along the continuum and accept the vaccine that I truly believe in. The last tip that I have for you is to engage the right messengers. So for my patients, and maybe for this audience, I'm a good messenger. I think I can share information clearly, but I may not be the right messenger for your patients. Maybe you are the right messenger, but I would also think broadly about engaging other people in the community that your patients will trust. So maybe that's you as healthcare professionals, doctors and nurses, but also think about other trusted people in the community like faith leaders, bring in other family members if needed. And in our country, racial concordance is very important. So people tend to trust other people of the same race. So in our program, we've done a lot of community outreach by engaging faith and community leaders that are racially concordant with our patients in order to help with our messaging. An important point here is that all of the messengers need to have the same message. We need to have a united front about how safe and effective this vaccine is. It's like my kids, if they don't like what they hear from dad and they go to mom, it's important that we have the same message. If they hear from one group that the vaccine is safe, and then from another group, hey, the vaccine might not be that safe, that becomes confusing. So engage the right messengers, and we need to make sure we're all aligned. Here are the tips. I'll show them to you again, and I'm happy to share these slides. Let's make the vaccine as convenient as possible. Understand where your patient is on the continuum of acceptance and why they're there. Ask permission to share information, share that consistent information through stories, and then ask the patient what they think, and engage the right messengers in order to get your information out there. I'm going to end on a note of opportunity. So this is hard work, and it doesn't always end up with a vaccine going into someone's arm. But doing this work gives us an opportunity to acknowledge barriers to engagement like racism and different cultural beliefs, and break down those barriers, forming individual and community connections. And while this is structured around the COVID vaccine, if we do this thoughtfully, we can actually build infrastructure that will build long-term relationships to meet our community's needs. I thank you again for the invitation. I've enjoyed the symposium, and I look forward to your questions after the rest of the discussion.
Thank you very much, Dr. Solomon. The final presentation that we'll be having this afternoon is entitled Social and Ethical Issues Related to the Rollout of COVID-19 Vaccine, Myths versus Reality. The presenter is Dr. Mike Campbell. Dr. Campbell is a senior lecturer in behavioral science and clinical psychology at the Faculty of Medical Sciences at Cave Hill in Barbados. He chairs the Research Ethics Committee, which jointly serves the University of the West Indies Cave Hill campus and the Barbados Ministry of Health and Wellness. He is a member of the Executive Committee of the Caribbean Network of Health Research Ethics Committees and the Queen Elizabeth Hospital Ethics Committee. Dr. Campbell is past president of the Barbados Society of Psychology and associate fellow of the British Psychological Society. Dr. Campbell, please.
Hello, good afternoon and greetings from Barbados. I'm hoping that everybody can see my screen. Is that true?
Yes, we are.
Very good, very good. So I've been invited today to really talk, I think, about variations on the theme of the last two presentations in this segment, the social and ethical challenges of rolling out COVID-19 vaccines in an ethical framework, and also with some specific reference to realities in parts of the Caribbean. So just as a starting point for ethical frameworks, I thought it would be useful to talk about different approaches to bioethics and how that can frame thinking about vaccines at different levels of health decision making. So ethics in general has to do with deciding what's good or bad or right or wrong on the basis of principles applied to given contexts. And so you'll see here that there are a few different frameworks. This list is not exhaustive, but it's useful. So the framework of duty or deontology, what are the obligations, role, responsibilities of health professionals, of doctors and nurses and policymakers? Much of Western medicine is really rooted in this ethic of duty, and that's evident, for example, in the Hippocratic Oath. Then utilitarianism refers to how much benefit is derived from a given decision and how many people benefit from that decision. You can also think about ethics in a context of rights established usually by formal or informal rules in a given context, and about the character of people making ethical decisions. So the right decisions are usually the kinds of decisions that good people make. And also, and particularly in healthcare, it's useful sometimes to think about ethic of care and that responsibility to care for fellow human beings has been emphasized in feminist ethical approaches. So thinking about that framework, we can think of three primary goals in the ethical allocation of vaccines, right? Reducing morbidity and mortality in the population, minimizing the impact of COVID economically and socially, and reducing inequalities that exist among groups. And on the right here in the orange, you can see some strategies to do this. And the previous presentations today have addressed some of these strategies. I think it's important to say that sometimes these strategies work in concert with each other, and there are situations in which strategies might suggest different and even incompatible different policy decisions, right? So you've heard these themes reflected in discussion today, right? Prioritize most vulnerable people, often that's elderly persons or people with comorbidities. Prioritize life cycle, vaccinate people who are likely to get more years of benefit from the vaccine. Prioritize those persons who have instrumental value, right? People with vital missions, such as healthcare workers, first responders, grocery employees, and you can think of others. The more egalitarian approach, which is everybody deserves equal access and first come, first served. And finally, prioritizing the reduction of spread in the population. So looking, in fact, for people in situations that are likely to increase the risk of viral spread, assisted living facilities, prisons, university residence halls, and so on. For those of you who are interested in this topic, I think that this article by Gupta and Moraine is a very useful introduction for further reading. So, following on Dr. Solomon's presentation, I just wanted to highlight that the impact of COVID and in fact concerns about vaccine distribution policies highlight existing health inequities. And in fact, some of the challenges reflect existing health inequities. And so those include discrimination, differential access and utilization of services, different vulnerabilities across occupational groups, and different vulnerabilities and different abilities to access care across socioeconomic groups and educational groups. So this is snapshot data from February 4th in the States, and you'll see the differences by racial group in mortality, and as you would know, African Americans are particularly vulnerable in terms of mortality, also indigenous Americans as well. And on the right, just to note that there is a landscape of vulnerability, and so there is a spatial component to vulnerability. This is at a level of, I think, county resolution, but even, you know, in terms of more micro geographies by neighborhoods, you can see in communities all over the world different vulnerabilities as a function of population density and public health infrastructure that varies in different parts of communities. So this is the latest data from CARFA. This is at the country level, obviously, but I think it's useful to keep in mind regionally that there are significant differences in terms particularly of incidence rate across the region, so that in a region that is usually so interconnected, perhaps a bit less now, at least in terms of travel, but these differential impacts of COVID across the region are of concern to all of us. So a couple of very specific issues that I think are certainly relevant in Trinidad and in Barbados as well. Did some reading on this issue of whether COVID vaccines are halal. So it turns out that the British Islamic Medical Association has issued this notice recommending the Pfizer vaccine. Doing some reading, preparing for the talk, I saw that the Oxford, Pfizer, and Moderna vaccines have indicated that they are halal both in terms of alcohol content and in terms of not using porcine gelatin as an additive for the vaccines. I'm not sure about some of the other vaccines in the pipeline, but it's also, I think, worth pointing out that there is some variability among religious authorities in terms of what they'd recommend about vaccines. In fact, the Fatwa Council at the UAE has recommended that even vaccines with porcine gelatin ingredients are in fact acceptable, the rationale being that the public health benefit outweighs the other concerns. So I think that engaging local religious leaders in terms of the messaging that's happening in your own communities is a key step to reaching out, particularly to Muslim populations. And also, actually, I should add, this is a concern for some Orthodox Jewish populations as well. So the other community of interest, one of the other communities of interest, is the Rastafarian community. And you'll see these articles. Let's see, the first one is from Jamaica. No, the first one is from Grenada. The second one is from Jamaica. The third is from Bahamas. And there is quite a bit of concern that is variable as well in Rastafarian communities. So I think that engaging in dialogue with community leaders is a key step to understanding what concerns might be in the particular communities that you're treating. And so understanding context and listening to communities is key to building trust, addressing misconceptions, and sharing accurate information. Important to acknowledge that mistrust is grounded in historical realities in many cases. All of you, I think, or most of you would be familiar with the Tuskegee study in the US, which is far from the only example of exploitative studies with African Americans, but it's probably the most salient example. And so when we are thinking about public health efforts for vaccine programs now, we really need to aim to promote legitimacy in the context of recognizing what the history has been and to engage different views in society and work together with community members who are in a position to influence communities. Transparency in communicating decisions, as well as the rationale for decisions and how they reflect community values is important. Leaders and influencers lead by example. This creates a sort of interesting ethical concern at times because in Barbados, this has been in the news and in other places in the world too, when particularly when political leaders step up to get vaccines to lead by example, there has been some criticism that that leading by example also came as the result of privilege that others don't have. And finally, just to say, to acknowledge in many parts of the world that conspiracy theories exist, and I have put a question mark after outlandish because clearly some people do not find these conspiracy theories to be outlandish. And it's really important, I think, to recognize that these concerns are often, most of the time, separate from something like a diagnosable mental health issue. It's very easy, I think, to sometimes be dismissive of theories that are way out in left field, but in fact, these beliefs do persist, and engaging people individually to hear their concerns and actually build a trusting therapeutic relationship is a key component of addressing resistance that comes from information that is inaccurate. And just to say, this is this describes British vaccination rates after the publication of the Wakefield article linking MMR to autism. So this is not COVID vaccines, but this is a useful demonstration of how the impact of false beliefs can really affect public health, health-seeking behavior in aggregate. So lessons from the past inform the present. And a summary statement is that really addressing community and individual concerns in a responsive and respectful way is crucial. Thanks very much.
Thank you very much, Dr. Campbell. So we have had 3 excellent presentations during this session, and the next step is to go to the Q&A segment. Of course, you were said before, there are questions in-house, questions online. Online, person can send their questions by text, as well as to put up your hand and you can ask your questions. I'll just ask one question that came up via text messaging, which we didn't get to in the previous session. CMO, it's perhaps related, it is directed to you. Will senior citizens be considered a priority if they're not being treated for any comorbidities or part of any NCD clinics, whether public or private? And if yes, what about persons who are not part of the CDAP program? How would they be identified and receive their vaccines?
Okay, so in addition to persons who have NCDs and those healthcare workers and frontline workers, persons over the age of 60, all persons over the age of 60, regardless of clinical status, will be considered. We have already written to the line ministry for a listing of those individuals. And of course, persons who present to the health facilities on their own will not be turned away as well. So you can visit the healthcare facilities once we have the vaccines allocated, and you will, once you fall within that group, you'll be offered the vaccine.
Okay. Thank you. Question?
Again, I can't wait to get my vaccine. My question is for Dr. Daniel Solomon. Our Caribbean diaspora is very unique people mixed with cultures and beliefs and different races. And as a practitioner, I've been trying to convince my patients in my practice, not only with the NCDs, but the older patients, just Dr. Parashram alluded to get a vaccine. So it's a two-pronged approach. One is that you have the younger people, as the last speaker was speaking, is that all the conspiracy theories, and they have to some extent influenced the older generation. And some of them don't go to the public clinics, they go privately. And a lot of them have said, Dr. Solomon, that they don't want to get involved in the vaccine. They have survived years without any sort of vaccine. And that generation are really not that interested. So what it means for the Ministry of Health and the University of Western is that all of us have to get involved to ensure that we have a healthy population and to get this vaccine rolled out as it comes. Thank you.
Thank you for that comment. I think it brings up an important point that, well, several important points. One is that we can't just target one group. We need to target the collective, because what we're looking at here is, of course, individual safety, but what we're really hoping for is community safety through herd immunity, right? So we can't just focus on one individual population in order to get the vaccine. Of course, we want to focus on the highest risk individuals first. But what you're bringing up, I think, is important, and maybe you know, a little bit of a challenge as we think about this. There are people who are hardline anti-vaxxers, right? That's sort of the term that we use. And what we need to do, and I think this happens outside the clinic room, like we really need to do a good job of public health messaging in order to counter all of the misinformation and disinformation. So I think about those as different things. Misinformation is just sort of things that people got wrong, and disinformation is intentional work in order to spread misinformation. And I think that we need to counter that as a profession and through public health messaging in order to sort of address some of these challenges that we face. But a complicated question. Thank you for it.
Yes, please.
Good afternoon. Good afternoon, everyone. Corey Dillon, representing the TTRNA. Very informative session this afternoon, and thanks to the ministry for inviting us. I just have two questions. One is firstly for the Honourable Minister. In light of all the skepticism and the anti-vaxxers and the possibility that many persons may not take the vaccine, is the government considering legislation? And my second question is directed towards the Chief Medical Officer. Is there a role for mental health professionals in the education and in the vaccine rollout? Thank you.
Okay, so thank you very much, Corey, for your question. I'm so glad to see TTRNA here. You all have a very serious role to play. Okay, the issue of mandatory vaccination, the answer in one word is no. The government is not considering making vaccinations mandatory. It runs counter to the Constitution, right to privacy, and everything else. Also, there are sound medical reasons why some people, a very small percentage, cannot be vaccinated. The Chief Medical Officer and the immunologist will go into that. So the answer is no, we are not considering that at any point in time. But we are highly recommending it using moral suasion and all the powers that we have within us to make vaccinations highly acceptable to the population. So thank you, Corey.
So the second question, of course, we are looking towards, and I think this symposium is really held towards healthcare workers, because we're looking to all healthcare workers to be the first to be vaccinated and to be advocates for vaccination for COVID-19. Mental health workers are no different, and we expect the support of the mental health community, nurses and physicians, as we do expect the support of all other healthcare workers in this initiative. So for sure, mental health. Yeah.
Okay, thank you. I see a hand is up, but I cannot read the name. So can somebody help me identify who was the first hand that is up? But while that is being done, I have some questions that were sent by text, and one relates to other health workers who were not able to attend this symposium. What is being done to educate those persons?
I'm on it.
Oh, okay. That's the same person?
Yes.
Yeah. So of course, this is, as I said, one of the initial programs for healthcare workers. We will have a series of programs led by the RHAs in the future, I think, going forward. So the Ministry of Health will have continued education through the RHAs for the healthcare workers, and of course through TTMA, TTRNA. Those persons are invited, and we expect that they will assist us in going forward to get to all the healthcare workers.
Thanks. Can someone guide with respect to the persons whose hands are up? The first one?
Yes, we now go to Ms. Brooms.
Hi, good afternoon. Thank you for the invite. Thank you for all the presentations. They were very informative. I have two questions. One towards the person who presented on the process for the vaccines to be accepted. Now, there's a lot of information that is in social media and on the web, and persons are accessing it. As a nurse, I will be confronted with persons who are asking questions based on these things that they would have seen. And one of the questions that I would have heard someone ask is the adverse effects. What are some of the adverse effects specific to AstraZeneca, and how are we to identify the groups that will be most affected by these specific adverse effects, so that we can do proper monitoring and surveillance of these persons?
Okay, I'm not sure if
Secondly,
oops, more questions.
one more. Now, I heard the Honourable, no, it wasn't the Honourable Minister. I think it is Dr. Parasram. Dr. Parasram stated that persons would be walking into the health centers and nobody wouldn't be turned away. Now, given my understanding of most of the physical layer of these health centers, we don't have the capacity as it is to deal with persons just walking in at random. So I know in the past, when there was an announcement that influenza vaccines were available, there was an influx of persons, and it was very unhealthy in terms of the overcrowding. So I would, in advance, would like to ask that things be put in place to prevent overcrowding at the health centers, because persons are going to go there as that is the point that they know that would be distributing vaccines. So persons will not be given the information, go to your health center, please, because that has happened in the past. Thank you.
Okay. So, yeah, in terms of the most common side effects for any vaccine is really pain at the injection site and fever. And we expect the same will be for this particular vaccine, and has been seen all over the world. Once WHO gives the approval, we are in the process of creating a fact sheet specific for AstraZeneca, the ministry, and that will be rolled out to the healthcare workers and they will be trained accordingly. With regards to the monitoring and surveillance aspect of it, everyone that has your vaccine, that have been given the vaccine, as I said before, will be continued for up to 6 months, if not a year, and they will be actively monitored to see if you have adverse reactions. I don't want to pull out, you can't pull out a particular person based on the research that suggests, I could be corrected, that a person will be at a heightened risk of a side effect, except those that would have presented previously with severe allergic type reactions. With regards to your question on overcrowding, and that's why we have not gone ahead and said COVID-19 vaccines will be at all our facilities. We picked 23 facilities in the first instance so we can manage the crowd. Those facilities were earmarked based on the size of the facility. They have additional space for persons to congregate for this vaccine alone, outside of what we have for COVID tents and the normal run of the clinic. So those 23 facilities would have met the criteria and they will be earmarked in the first instance. If we have to scale up, then of course we'll look to the mass sites and then maybe to go into the additional sites if need be. Okay.
Okay, thank you. Next we have, I would like to invite Ms. Valiant. Okay, I would now invite Mr. Mark West instead.
Good afternoon, very good presentations. I am Dr. Angel Joseph.
Yes.
Hello.
Yes, please proceed with your question.
Hi, good afternoon. I'm Dr. Mark West, one of the cardiothoracic surgeons at Mount Hope. Thank you very much for the invitation. An excellent meeting led by the Ministry of Health and University of the West Indies. I have two quick questions. First of all, having received the vaccine, how long will the immunity to the virus last for? And also, is there a difference for the different types of vaccinations being offered? That's the first question. The second question, more of a practical one, may have been answered. Having received the vaccine, will there be an official personal documentation from the Ministry of Health stating that you've had that vaccine, the so-called passport, so that you can show people that you've had this vaccine if required for travel purposes, etc.? And do they have to be an antibody or blood test determinant that you are in fact immune? Thank you.
You want to take the first one? Yeah.
Okay, so turning to your question about how long after vaccination a person will be immune to the virus, first of all, we have to remember that these vaccines have only just been developed and rolled out to the public. So the length of time that we know they will last is the length of time that they've been given to people. Those that have been used in earlier trials would have been at least maybe 9 months ago. And as far as I know, they've seen the antibody responses remaining high for at least 6 to 9 months, I think. I think the immunologist might be able to give a better answer, but to remember the numbers. But definitely, the issue we have is that we only have that amount of time to speak to. It could be longer, it could be a year, it could be a year and a half. Okay, thank you.
You want to add anything or yeah?
Good afternoon. Yes, so what Professor Carrington said is correct. It's a case of we are still collecting data with regards to the length of the immunity, but thus far, for the number of months that you did indicate, the immunity has seemed to have lasted this long, but we are still collecting information with regards to that.
Okay, yeah, and in terms of the forms, so you will be getting on your immunization card, which is a local immunization card, you will be given the batch number, the date you received the vaccine for both doses on that form. So you'll keep it just as you do your other immunization cards. For the purpose of proof of travel, what you have to get is an international card, which will be given out from the offices of the CMOHs in Trinidad and Tobago. You basically show your the local card presented to the CMOH, the counter stamp on an international card, which is used already for yellow fever and other viruses, other immunizations, and that will serve as your international card if you have to travel abroad.
Okay, thanks. Next we have Ms. Valiant. Please ask a question.
Good afternoon. Very good presentation for all the presenters. I would like to ask you a question. Oh, okay. Let me introduce myself. I am Dr. Angel Justice from the Faculty of Medical Sciences, Department of Paraclinical Sciences. I would like to ask you just a question. If there are any other vaccine apart of the AstraZeneca vaccine that may be considered in the future by the Ministry of Health.
Presentation, we are looking at other vaccines as well. We have been looking at the technical data for the Johnson & Johnson vaccine, AstraZeneca, Pfizer, Moderna, and a few others, Sinopharm as well out of China. So we have been looking at the technical data, as Trinidad will only use a vaccine once it's approved for emergency use by the WHO. So far, Pfizer has done that. As they come on stream and as time passes, we will look to WHO to see if they add additional vaccines to the EUL. And once that is done, of course, we can consider it for use in the country.
Okay, now I invite Mr. Driver.
Okay, just so to point out that you've taken 2 more questions, and then there are a number of persons whose questions were not answered in the text. We'll be collating those questions and preparing answers, which will be on the Ministry of Health's website in the FAQ section. But 2 more questions, please.
Okay, Mr. Driver.
Hi. Hi, this is Dax Driver here from the MG Chamber. Thank you for inviting us to be part of this session today. So just a question and an offer. So the question is, the vaccine acceptance data for Trinidad and Tobago, has that been disaggregated by manufacturer? Do we know if there's a difference in how people think about the different vaccines coming from different manufacturers? So that was the question. And then just the offer, I think that employers might have a role to play in building confidence amongst employees. So as we're there to help roll out any communications to our employees, and the chambers can do this to their members, and then members can do it through to employees. But perhaps we should think about some resources to help people do that.
So let me just start with the the second part of the question. I mean, is more actually we'll be happy to work with you all in the chamber, and we continue to do so through the COVID-19 pandemic to roll it out to all persons. The first part of the question, I don't know if you wanna. I think he was asking if there was specific data related to the individual vaccines coming out of the study, and I don't think it was specific to any particular type.
No,
right?
no.
Yeah.
Yeah, just to answer that, there is no study we come across that talk about any specific vaccine. It is all about generic, that what we call, what about the COVID-19 vaccine. And these studies are conducted as a general study, not about specific vaccine about that.
Question for online. Chandra Sarup.
Hi, good afternoon. My question is with regards to the travel policy for healthcare workers. Following up on what Dr. Mark West had asked before about the travel documents, is the Ministry of Health going to be speaking with the Ministry of National Security about developing an exemption policy for healthcare workers once they are vaccinated? And are we thinking about using this as part of our strategy for influencing healthcare workers to take the vaccine? And secondly, with regards to the South African and the Brazilian variants, the NHI, through Dr. Fauci, they are actually thinking about the booster shot later down the road. Is the Ministry of Health speaking with PAHO WHO about implementing a plan for accessing those boosters if and when they do come on board?
Thank you. I think this is time for the Minister of Health to come in here. Could you repeat your first question, please, about travel and exemptions? I didn't quite understand it. Just repeat the first question about travel exemption policy for healthcare workers.
So if the healthcare workers get the vaccines and we get the immunization card, the travel card document, will the Ministry of Health be speaking to the Ministry of National Security about developing a policy, an exemption policy for healthcare workers who have been vaccinated, making it easier for us to travel once we have been vaccinated with the COVID-19 vaccine?
Okay, so speaking to the issue of travel, there will be one policy for any citizen to travel. It would not be compartmentalized to say you have one policy for healthcare workers, one policy for other categories of workers. It will be the same policy that applies to travel for yellow fever or anything else. So it'll be one policy once you are vaccinated, and if the receiving country requires you to show proof of vaccination. So for example, right now, to go to Jamaica, for a Trinidadian to go to Jamaica, you must have proof and show proof of vaccination. Okay, and I think that more or less answers that. The second thing is the question that you asked. Just repeat the second question now. The question was a bit...
Sorry, yeah, sorry. So I asked, so you're saying that there's going to be one policy, whether we are vaccinated or not.
For citizens, for citizens,
yes. However,
right.
Can't we look at developing an exemption policy for healthcare workers who have been vaccinated, and in so doing, use this as a strategy to encourage healthcare workers to take the vaccine?
Okay,
Can't we look at that?
Yeah. To exempt you from what? I'm trying to figure out. To exempt you from what? To leave the country or come back into the country?
Both. Travel to and from Trinidad and Tobago.
Yeah, so I have addressed the issue of traveling outside of Trinidad and Tobago. If you're a healthcare worker outside of Trinidad and Tobago wishing to come back in, that's a different issue. But once you are vaccinated in country, whether you're a healthcare worker or not, the same policy will apply. Okay? So I hope that brings some clarity to the issue, just as it applies for yellow fever. Okay? You want to ask your second question?
It's about the booster. So
the booster shot? Yes. So we have said several times that once we start to vaccinate individuals in Trinidad and Tobago, so if I vaccinate you, and if I vaccinate people in this hall, we will be reserving the second dose for those people. So we are getting between 100 to 120,000 doses in the first instance. And let me say that because there was an unfortunate commentary in one of the newspapers today. We are getting, in the first instance, 100 to 120,000 doses. That means we'll be vaccinating between 50 to 60,000 persons using that batch. Once we reach that threshold of 50 to 60,000 persons, we will be keeping your second dose in reserve for you. So you are more or less guaranteed that you will get your second shot, which is the booster shot. So your first shot is a primer, you get that, then we keep in reserve the second shot, which is your booster for you, okay? So I hope that answers your concerns.
no, I'm not talking about the second shot. I'm talking about the NHI is actually talking about a booster probably 6 months down the road after the first two shots. Are we talking to PAHO WHO about accessing that
So
if and when it's needed?
Yeah, so thanks. Thanks for that. So PAHO WHO will guide us, as Dr. Parasram said, The AstraZeneca vaccine goes for EUL on the 15th of February. Based on that endpoint data, then we will determine what happens after that. But for now, the protocol is you get your primer shot and then you get your second booster shot, okay? But we are always in contact with PAHO, WHO, so if there's any change to the protocols, we will inform you. Thank you.
Okay, thank you very much. So I have to bring the symposium to a close with a quick wrap up. We had a number of stimulating presentations, which began with Professor Carrington talking about a project on genomic surveillance. Then Dr. Alexander gave an excellent overview of the development and approval of COVID-19 vaccine with a focus on their safety and efficacy. Then Dr. Wheeler spoke about the kovacs facility, in which she gave an update on the facility's objectives, progress, and upcoming timeline. Dr. Parashuram then gave a presentation where she highlighted the pre-planning steps, as well as the plans for vaccine arrival, storage, and distribution, and administration, including both the public and private partnership in the country. You had a break. After the break, Dr. Sa gave the results of his research project, which showed acceptance rates of 38%, which is low but consistent with what other studies have shown. Dr. Daniel then spoke about overcoming vaccine skepticism. He spoke about the 5 C's of vaccine hesitancy. Importantly, he provided practical tips on how to address them. And Dr. Mike Campbell addressed some of the ethical issues related to the distribution and uptake of vaccine, such as among religious groups, as well as the impact of false beliefs. I would like to end by a short vote of thanks, starting with the Minister of Health and the Dean of the Medical Faculty for their support in actually hosting this symposium. Without their support, there would have been a symposium this afternoon. I also would like to point out that we had a planning committee for this symposium. From the UWI, we had Ms. Marsha Ivy, Ms. Chriselle Barker, Ms. Shelley Hunt, Ms. Nikisha Headley, Dr. Arlene Williams, and Dr. Calamaria Alexander. We had 2 critical persons for marketing and communication, Ms. Chanel Glasgow and Ms. Wendy Maynard. Thanks so very much. They did a lot of work. Ministry of Health, Ms. Candice Alcantara and Ms. Nikita Zephyrin, who made excellent contribution. Of course, we have the ICT and AV team, Colin Knight, Alan Christopher, Mark Smith, Marlon Sampson, Dexter Superville. Of course, the security and the housekeeping who was there cleaning up, who was just sanitizing, after each person spoke. But I must end by thanking all the presenters and the participants for your searching questions, I end by noting that it is the first vaccine symposium to be hosted by the UE and Ministry of Health. Having set this tone, we look forward to having more, targeting different audiences such as the media, such as religious groups. And I also encourage the various professional associations to convene your own vaccine education programs for your stakeholders. UE, Ministry of Health will be happy to provide necessary technical support. On that note, I'd like to end the symposium and thank everyone and have a good and safe afternoon. Goodbye.